Part 1. Mask Science, Efficacy and Effectiveness. Framing the question. We can discover whether or not masks work as a public health measure by answering 4 basic questions. 1. What should we expect to observe if masks mitigate the spread of respiratory viruses and other pathogens? 2. What do we actually observe? 3. What is the quality and quantity of the evidence base supporting claims of mask efficacy? 4. What other important scientific aspects of the problem need to be considered? Absence of evidence is not evidence of absence, but finding evidence of absence is often pretty straightforward. Evidence of absence can come from direct observation, such as when you survey a refrigerator where you expect to find milk and, finding it to be empty, then conclude that you are out of milk. Evidence of absence can also come from incompatible positive findings. For example, if you establish that a man was physically present in California at a particular time, you can rule out the idea that he was physically present in New York at the same time. Contrary to certain tropes, it is entirely possible to prove a negative. Science often advances most effectively by falsifying hypotheses. A famous quote attributed to Thomas Edison encapsulates this approach. If I find 10,000 ways something won't work, I haven't failed. I am not discouraged because every wrong attempt discarded is another step forward. Not all scientific evidence is created equal. The weakest types of scientific evidence are conjecture, also known as modeling, and expert opinion. Laboratory studies are stronger, but hypotheses developed in controlled conditions need to be tested and verified by real-world observational studies and randomized controlled trials. Real-world observational studies are better than laboratory studies, but are often subject to a number of confounding biases. The following is only a partial list. Selection bias occurs when there is a subtle loss of essential randomization, such as when an unusually high proportion of anxious people volunteer to participate in a study about the prevalence of anxiety in the general population. Recall bias occurs when results of the study are highly dependent on the participants' ability to recall information, as when Solomon Asch's conformity study participants universally underestimated the extent to which they succumbed to group pressure. More on Asch's famous series of experiments in the section on mask psychology. Surveillance bias occurs when looking more closely at a particular group finds more of a particular outcome, such as when testing a subset of the population twice as much as everyone else can make disease incidence look higher than it actually is. Measurement bias occurs when data is collected in a systematically distorted manner, such as cherry-picking by discarding all the data that would falsify one's hypothesis. Social desirability bias occurs when responses are skewed in a direction that subjects find less personally embarrassing or believe will make them look better. Why yes, now that you mention it, I do brush and floss 7 days a week. Why do you ask, doctor? Publication bias occurs when studies are selectively published based on their results rather than on the inherent quality of the research they contain. This was especially rampant during COVID. Randomized controlled trials are usually held up as the gold standard of scientific studies because they seek to eliminate as many confounding variables as possible. They are, on average, the strongest types of studies. They often require the most effort as well. Meta-analyses, or systematic reviews, aggregate and assess the results of multiple individual lesser studies. Meta-analyses, or systematic reviews, aggregate and assess the results of multiple individual lesser studies. Meta-analyses of randomized controlled trials are generally considered the highest quality of evidence, but the outcomes of even these can be skewed or manipulated depending on which studies are selected for the review and analysis. Garbage in, garbage out. Even within a category, the evidential quality of a study can vary dramatically depending on factors such as size, duration, observational detail, methodology, and the specific question being examined. Different subtypes of studies within each of these categories also vary considerably in methodology and overall strength. For example, there are multiple different subtypes of observational studies which can range from weak to quite strong. These range from case studies of single individuals to prospective and retrospective cohort studies with thousands of participants. Quite apart from extensive anecdotal evidence and independent research, there were more than 100 published studies by the middle of 2021 which, in combination, provided decisive evidence that masks do not mitigate the spread of respiratory viruses, or for that matter other pathogens, to any extent which would even come close to justifying mandates. This number more than doubles if you include studies which provide background evidence that would disfavor mask use even if masks could be shown to work. To download a free printable PDF poster that provides a visual overview charting the category and content of more than 270 mask-related studies at a glance, visit www.thebookonmasks.com/extras. What should we expect to observe if masks work? What would the scientific evidence, especially randomized controlled trials, need to show for us to conclude that masks work to mitigate the spread of respiratory viruses? If the hypothesis that masks are effective at mitigating the spread of respiratory viruses and other pathogens is true, then a preponderance of the best available scientific studies, especially randomized controlled trials, should show us the following. We should see masks provide clear and convincing benefits against postoperative infections when all members of surgical teams are masked compared to when some surgical team members are unmasked. We should see masks provide clear and convincing benefits against viral transmission within households when masks are worn compared to when they are not. We should see masks provide clear and convincing benefits against viral transmission when medical masks are worn compared to no masks at all among more densely packed subgroups in the community, such as Hajj pilgrims or college students living in dorms. We should see masks provide clear and convincing benefits against respiratory viral infections among members of the general population who wear masks compared to those who do not. We should see clear and convincing benefits against viral respiratory infections among healthcare workers who wear top-quality medical masks like N95 respirators when compared to those healthcare workers who only wear standard medical surgical masks. We should see independent, systematic literature reviews and meta-analyses of multiple randomized controlled trials involving mask use, consistently finding clear and convincing benefits against respiratory viral transmission from mask use. We should see studies purporting to show masks work generally being larger, longer, stronger, more rigorous, and more numerous than studies which show no benefits from wearing masks. What do we actually observe instead? The greatest quantity and highest quality of scientific literature indicates that masks do nothing to mitigate the spread of respiratory viruses. Randomized controlled trials show masks do not work. There are at least 25 randomized controlled trials examining the efficacy of face masks. If it were true that our use of masks provides protection for others, we should expect to see a statistically significant difference in postoperative microbial infection rates when various medical procedures are conducted with masked or non-masked surgical personnel. Yet randomized controlled trials from thousands of surgeries in hospital operating rooms show no clear and convincing benefits against post-surgical infections. The non-significant differences that are observed tend to show a slight increase in the rate of post-surgical infections with the fully masked surgical teams. If masks fail to make a difference in these post-surgical bacterial infection rates, there is no reason to suppose they will have an effect on much smaller respiratory viruses, which are both more easily transmitted and harder to filter. A Swedish randomized controlled trial conducted over 2 years and including the same operating teams in the same operating rooms doing the same types of procedures on the same patient pool found that after 1,537 operations performed with face masks, 73, 4.7% wound infections were recorded. After 1,551 operations performed without face masks, 55, 3.5% infections occurred. This difference was not statistically significant, and the bacterial species cultured from the wound infections did not differ in any way. Likewise, an Australian randomized controlled trial found that surgical site infection rates did not increase when non-scrubbed operating room personnel did not wear a face mask. In the mask group, all non-scrubbed surgical staff wore a mask. In the no-mask group, none of the non-scrubbed surgical staff wore masks. Out of 811 participants who completed the study, a total of 83, 10.2% surgical site infections were recorded. 46, 11.5% were in the masked group, and 37, 9% in the no-mask group. The difference was not statistically significant. Randomized controlled trials of respiratory viral transmission within households show no clear and convincing benefits against viral transmission when masks are worn versus no masks. A German cluster randomized controlled trial of masking in 84 households, totaling 302 participants, found no decrease in the transmission of influenza when masks were worn. In primary intention-to-treat analysis of all data, the interventions did not lead to statistically significant reductions of secondary attack rate. In a 2011 Thailand cluster randomized controlled trial involving 442 index infected children and 1,147 household members, secondary influenza attack rates between the hand washing and the hand washing plus face mask group were identical. The authors concluded influenza transmission was not reduced by interventions to promote hand washing and face mask use. A cluster randomized controlled trial was conducted in New York with 509 primarily Hispanic households, 2,788 persons total, over a period of 19 months. It examined the effects of 3 interventions in 3 study cohorts: education, education plus hand sanitizer, and education plus hand sanitizer plus face masks. The authors found that there were no significant differences in rates of upper respiratory infection, influenza-like illness, or influenza by intervention group. A 2008 cluster randomized controlled trial by Cowling and colleagues compared 3 cohorts, groups, no intervention versus face masks versus hand hygiene in 122 households. They found that the laboratory-based or clinical secondary attack rates did not significantly differ across the intervention arms. An even more well-known study by McIntyre and colleagues 1 year later in 2009 described Cowling's 2008 study as follows. Another recent study that examined the use of surgical masks and hand washing for the prevention of influenza transmission also found no significant difference between the intervention arms. McIntyre and colleagues' 2009 randomized controlled cohort study of 143 households included 286 adult participants and found that influenza-like illness was reported in 21 out of 94, 22.3% in the surgical mask group, 14 out of 92, 15.2% in the P2 respirator mask group, and 16 out of 100, 16% in the control group, respectively. We concluded that household use of face masks is associated with low adherence and is ineffective for controlling seasonal respiratory disease. Did you catch that? In this study, too, the no-mask control group contracted influenza-like illness no more frequently than either of the 2 masked groups. In 2009, Cowling and colleagues conducted another cluster randomized controlled trial involving 322 infected index cases and their household contacts. They found that hand hygiene with or without face masks seemed to reduce influenza transmission, but the differences compared with the control group were not significant. More importantly for the purposes of our analysis, they also reported that no significant difference was found between the face mask plus hand hygiene group and the hand hygiene group in RT-PCR confirmed influenza virus infections in household contacts. Here again, adding a face mask on top of hand hygiene made no difference. In a 2010 French cluster randomized controlled trial, including 306 contacts in 105 households, examining the efficacy of surgical face masks for limited influenza transmission, the authors reported, "We observed a good adherence to the intervention. In various sensitivity analyses, we did not identify any trend in the results suggesting effectiveness of face masks." In 2016, McIntyre and colleagues described the French study as follows. Influenza-like illness was reported in 16.2% and 15.8% of contacts in the intervention and control arms, respectively, and the difference was not statistically significant. The 2016 McIntyre study just quoted was yet another randomized controlled trial on masks. This particular randomized controlled trial was cited as evidence that masks do not work by 19 states in a joint lawsuit against the CDC's mask mandate. This study was done in the same vein as the 2010 French study just listed, and is also noteworthy for how it characterizes previous randomized controlled trials on masks in a healthcare setting from 2011, 2013, and 2015. Cloth and medical masks were originally developed as source control to prevent contamination of sterile sites by the wearer in operating theaters. However, their effectiveness in preventing surgical site infections is yet to be proven. Mask use as source control in healthcare settings has now been included in standard infection control precautions during periods of increased respiratory infection activity in the community, yet there is no clinical efficacy evidence to support this recommendation. The 2016 McIntyre study examined the effects of medical masks as source control using transmission of influenza-like illness from 245 index cases, half masked, half unmasked, to 597 household contacts. Though the authors repeatedly emphasized the lower number of infections in the masked group, 2 fewer infections total between the study cohorts, they nevertheless ultimately conceded, "We did not find a significant benefit of medical masks as source control." Randomized controlled trials among more densely packed subgroups in the community, such as Hajj pilgrims or college students living in dorms, likewise show no clear and convincing benefits against viral transmission when medical masks are worn versus no masks. An interconnected trilogy of cluster randomized controlled trials was conducted involving 7,851 total participants using tents of Hajj pilgrims as the cluster randomization units. Though the 2014 pilot study of 164 participants suggested a possible protective effect from medical masks, the larger follow-up studies with 7,687 participants found that masks were not associated with decreased risk for infections in Hajj pilgrims, even when an infected index case was present in the same tent. In intention to treat analysis, face mask use was neither effective against laboratory-confirmed viral respiratory tract infections nor against clinical respiratory infections, not even in per-protocol analysis. Two cluster randomized controlled trials by Aiello et al. Were published in 2010 and 2012, which looked at 2,475 student participants living in residence halls. These compared a control group to an intervention cohort with face mask only and a face mask plus hand hygiene intervention cohort. In 2010, the authors reported that both intervention groups compared to the control group showed cumulative reductions in rates of influenza over the study period. However, they admitted in the same sentence, results did not reach statistical significance. The 2012 study reiterates this point. Statistically significant findings were not observed for the face mask only group when compared to the control group. This is consistent with the studies listed previously, which found that hand hygiene may have a beneficial effect, but that the addition of a face mask did not lead to a decrease in respiratory viral infections. The best randomized controlled trial in the general population involving medical masks versus no masks was Bundgaard et al.'s Danish face mask study, which shows no clear and convincing benefits in the medical mask group against SARS-CoV-2 and other respiratory viral infections. The Danish face mask study is important for being the first randomized controlled trial to examine SARS-CoV-2 infections in masked versus non-masked civilian populations. It is also by far the highest quality one to date. 4,862 participants completed the study, 2,392 masked, 2,470 non-masked. The authors found no statistically significant difference in SARS-CoV-2 infection rates between the masked 1.8% infection rate and non-masked 2.1% infection rate study cohorts. The study cohort that reported wearing the mask exactly as instructed had a 2% SARS-CoV-2 infection rate. There were also no statistically significant differences between the study cohorts in rates of other respiratory viral infections. In addition, the supplemental data found no statistically significant interaction in viral infection rates between wearers and non-wearers of eyeglasses, suggesting that eye protection measures like face shields are not beneficial. Also, the participant exit survey documented that the mere act of wearing a mask for 2 months produced a dramatic shift in beliefs about masks. We will explore this in more detail in Part 3 when we look at mask psychology. Only one randomized controlled trial purports to show a statistically significant benefit from face masks. The randomized controlled trial most favorable for face mask efficacy was conducted in Bangladesh in 2021, when Abuluk and colleagues reported that cloth masks produced no statistically significant benefits, and that medical masks made an absolute difference of 1% in COVID infection rates, 8.6% COVID infection rate in the control cohorts versus 7.6% in the mask cohorts. This is a relative risk difference of 12%. Even taking Abuluk's study at face value, it is worth pointing out that a drug with 12% efficacy would not even be approved for use, much less mandated. Nevertheless, even the results above likely overstate the case for masks, because Abuluk's study was seriously flawed, as described by 2 subsequent studies which reanalyzed the data from that trial and found no benefit to face masks. The first reanalysis noted that the lack of blinding of the observers in the study contributed to highly significant differences between the population of the treatment and the control groups. These differences are much more significant than the measured differences in symptomatic seropositivity. In other words, the masked group and the control group were too dissimilar for any beneficial differences in COVID infections to be attributed to masks. The second reanalysis was equally, if not more, devastating for the Bangladesh mask study. The authors concluded, All we can conclude is that there is a 95% chance that mask intervention would result in anything between 19,240 fewer positives and 18,500 more positives among every 100,000 people. The results therefore provide essentially no support even for the weak surrogate hypothesis that the mask intervention procedures reduce the seropositivity rate. This would be much like flipping 201 coins, observing 101 heads and 100 tails, and concluding that all coins are more likely to land on heads than tails. Jefferson et al.'s 2023 Cochrane review of mask studies also rated the Bangladesh mask study as having a high risk of selection bias, detection bias, reporting bias, and performance bias. In a later interview, the lead author of the Cochrane review stated the same criticisms of the Bangladesh face mask study that others had voiced. That was not a very good study, because it was not a study about whether masks worked. It was a study about increasing compliance for wearing a mask. Additionally, according to the Bangladesh mask study author's own statements, the observed benefits of face masks were entirely concentrated in users over age 50. This age-differentiated result from a mechanical intervention strongly suggests that the reported benefits were due to observation, sampling, and reporting biases, and even if these were not present, the results of Abelak's study would provide no evidence for benefits of masking anyone under age 50. If the theories behind compulsory mask use and mask guidance accurately reflect the reality of viral transmission, and if face masks are truly effective at mitigating the spread of respiratory viruses, we should expect to see a preponderance of randomized controlled trials finding that healthcare workers who use higher quality masks, such as fitted N95 respirators, experience clear and convincing benefits against viral respiratory infections when compared to those healthcare workers who only wear standard medical surgical masks or non-fitted N95 respirators. What we actually observe from randomized controlled trials among healthcare workers is no clear and convincing benefits against respiratory viral infections from higher quality N95 mask use over medical surgical masks and non-fitted N95 respirators. A randomized controlled trial conducted from 2020 to 2022 on 1,009 healthcare workers, which compared the efficacy of surgical masks to fit-tested N95 respirators, found no statistically significant difference in SARS-CoV-2 viral infection rates between the healthcare workers who used medical masks and those who used fitted N95 respirators. These results were consistent with those of an earlier 2009 randomized controlled trial headed by the same author examining 446 nurses in Ontario hospitals. Influenza infection occurred in 50 nurses, 23.6% in the surgical mask group, and in 48, 22.9% in the N95 respirator group. Notably, the earlier study also looked at coronavirus infection rates and had similar findings. 4.3% rate of coronavirus infections in the surgical mask group versus 5.7% in the N95 respirator group. Moreover, the 2022 study was particularly notable because it excluded vaccinated healthcare workers and healthcare workers with prior SARS-CoV-2 infection, thus avoiding a strong potential confounder. By far the most rigorous and extensive single randomized controlled trial comparing medical masks and N95 respirators to date followed over 4,000 healthcare workers at 137 outpatient study sites in 7 medical centers across the United States over 4 flu seasons from 2011 to 2015. It was also partially sponsored by the CDC. In this pragmatic cluster randomized controlled trial that involved multiple outpatient sites at 7 healthcare delivery systems across a wide geographic area over 4 seasons of peak viral respiratory illness, there was no significant difference between the effectiveness of N95 respirators and medical masks in preventing laboratory-confirmed influenza among participants routinely exposed to respiratory illnesses in the workplace. In addition, there were no significant differences between N95 respirators and medical masks in the rates of acute respiratory illness, laboratory-detected respiratory infections, laboratory-confirmed respiratory illness, and influenza-like illness among participants. This study by itself is enough to show that the CDC and every other state public health agency either knew better or should have known better than to recommend respirator masks over surgical masks for the prevention of SARS-CoV-2 or any other respiratory viral infection. The most famous series of randomized controlled trials regarding masking in healthcare settings was conducted from 2011 to 2015 by McIntyre and colleagues. These compared the efficacy of medical masks versus N95 masks, and double-layered cotton cloth masks versus medical masks. They involved a total of 4,717 healthcare workers in China and Vietnam. In addition, the 2011 study included a convenience non-randomized, non-masked control group of 481 healthcare workers. Contrary to current masking theory, McIntyre's 2011 study, which among other things compared fit-tested and non-fit-tested N95s, found that the non-fit-tested N95s outperformed the fit-tested N95s. After adjustment for clustering, non-fit-tested N95 masks were significantly protective compared to medical masks against clinical respiratory infection, but other outcomes were not significant between N95 and medical masks. Keep in mind that clinical respiratory infections include not just viruses, but bacteria and fungi as well, which are many times larger and thus easier to filter out. McIntyre's 2013 study states, "The original purpose of medical masks was to prevent microbial contamination of wounds while worn by surgeons during surgery, hence their common name, surgical masks. Yet randomized controlled trials show no efficacy against wound contamination. Masks in community settings have no clearly proved efficacy." McIntyre's 2015 study describes the 2011 and 2013 McIntyre studies as two previous randomized controlled trials in which no efficacy of medical masks could be demonstrated when compared with control or N95 respirators. It goes on to state that observations during SARS suggested double masking and other practices increased the risk of infection because of moisture, liquid diffusion, and pathogen retention. The most prominent finding of McIntyre's 2015 study was that the best-case scenario for cloth mask use, trained healthcare workers who washed them daily, still produced a statistically significant higher rate of respiratory viral infection than any of the other study cohorts. Cloth masks resulted in significantly higher rates of infection than medical masks, and also performed worse than the control arm. The rates of all infection outcomes were highest in the cloth mask arm. The results caution against the use of cloth masks. The magnitude of difference raises the possibility that cloth masks cause an increase in infection risk in healthcare workers. If healthcare workers are warned against using cloth masks, forcing those same cloth masks on the general public cannot be justified. A 2020 post hoc reanalysis found that the higher rate of viral infection in the case of cloth masks relative to medical masks disappeared for cloth masks which were disinfected in the hospital laundry, but this finding merely reinforces the negative implications for universal community-level cloth masking. Finally, McIntyre's 2015 study also reported that the rate of virus isolation in the no-mask control group in the first Chinese randomized controlled trial was 3.1%, which was not significantly different to the rates of virus isolation in the medical mask arms in any of the three trials, including this one. The values reported are reproduced in the table below for side-by-side comparison. It is noteworthy also that these results are within 1 to 1.3% of the SARS-CoV-2 infection rates found in Bungard et al.'s Danish face mask study from 2020. Viral attack rates, all viruses. Non-randomized, no-mask control group, McIntyre 2011, 3.1%. Surgical medical masks, McIntyre 2011, 2.6%. Surgical medical masks, McIntyre 2013, 3.3%. Surgical medical masks, McIntyre 2015, 3.3%. Systematic reviews and meta-analyses show masks do not work. Repeated, independent, systematic literature reviews and meta-analyses, including at least 4 done in the context of COVID and evaluating many of the mask use randomized controlled trials cited earlier, have also consistently found that masks provide no clear and convincing benefits against respiratory viral infections, and that N95s confer no clear and convincing benefits over surgical masks. A 2016 systematic review and meta-analysis compared the efficacy of surgical masks and N95 respirators. In the meta-analysis of the clinical studies, we found no significant difference between N95 respirators and surgical masks in associated risk of A. Laboratory-confirmed respiratory infection, B. Influenza-like illness, or C. Reported workplace absenteeism. Importantly, this study also notes that N95s appear to have a benefit in laboratory settings, but that this does not seem to carry over to clinical settings. A 2017 meta-analysis that found a slight protective effect of N95 respirators against bacterial infections nevertheless concluded, compared to medical masks, N95 respirators conferred superior protection against clinical respiratory infections and laboratory-confirmed bacterial but not viral infections or influenza-like illness. The authors also stated, single-use medical masks are preferable to cloth masks, for which there is no evidence of protection and which might facilitate transmission of pathogens when used repeatedly without adequate sterilization. A World Health Organization technical report published on the eve of COVID, September 19, 2019, included the results of its own systematic literature review and meta-analysis, evaluating 10 randomized controlled trials on masks, all of which we have already reviewed. In its own words, the report's overall result of evidence on face masks was that there was no evidence that face masks are effective in reducing the transmission of laboratory-confirmed influenza. The report also specifically stated that reusable cloth face masks are not recommended. Yet in less than 9 months, despite no change in the balance of the evidence, those same reusable cloth masks would go from being not recommended to mandated across the globe. A 2020 meta-analysis made specifically in the context of COVID-19 concluded, compared with N95 respirators, the use of medical masks did not increase laboratory-confirmed viral, including coronaviruses, respiratory infection, or clinical respiratory illness. The authors went on to state that there is no convincing evidence that medical masks are inferior to N95 respirators for protecting healthcare workers against laboratory-confirmed viral respiratory infections during routine care and non-aerosol generating procedures. Another meta-analysis made specifically in the context of COVID-19, and also one of the most thorough and straightforward, concluded, although mechanistic studies support the potential effect of hand hygiene or face masks, evidence from 14 randomized controlled trials of these measures did not support a substantial effect on transmission of laboratory-confirmed influenza. The study authors also stated, we did not find evidence that surgical-type face masks are effective in reducing laboratory-confirmed influenza transmission, either when worn by infected persons, source control, or by persons in the general community to reduce their susceptibility. Another 2020 meta-analysis concluded there were no statistically significant differences in preventing laboratory-confirmed influenza, laboratory-confirmed respiratory viral infections, laboratory-confirmed respiratory infection and influenza-like illness using N95 respirators and surgical masks. The use of N95 respirators compared with surgical masks is not associated with a lower risk of laboratory-confirmed influenza. Cochrane's systematic reviews of surgical infection control trials published since 2005 have consistently concluded that there was no statistically significant difference in infection rates between the masked and unmasked group in any of the trials. The conclusion of the 2023 Cochrane review, Physical Interventions to Interrupt or Reduce the Spread of Respiratory Viruses, was no different. The authors reviewed 12 of the randomized controlled trials already summarized, with over 275,000 total participants, and concluded with moderate certainty, wearing masks in the community probably makes little or no difference to the outcome of influenza-like illness or COVID-19-like illness compared to not wearing masks. In a February 2023 interview, the review's lead author, Dr. Tom Jefferson, stated, the evidence really didn't change from 2020 to 2023. There's still no evidence that masks are effective during a pandemic. What did change in 2020 was the politics around masks. In that same interview, Dr. Jefferson revealed that the 2020 edition of the Cochrane Review on Masks, which included observational studies and also showed no benefit from masks, was ready for publication early in 2020. However, publication was mysteriously and unexpectedly delayed by 7 months for extra peer review. That 7-month delay period was when the mask hysteria really took off and ossified. Coincidentally, Bill Gates became one of Cochrane's major donors in 2016. Earlier systematic reviews and studies were consistent with these, such as Bali's 2009 conclusions after surveying trials from 1966 to 2007. It is still not clear that whether wearing surgical face masks harms or benefits the patients undergoing elective surgery. In 2012, Benreza et al. Conducted a systematic literature review which included 17 randomized controlled trials. The authors wrote, none of the studies established a conclusive relationship between mask or respirator use and protection against influenza infection. Further, a simulation study found that strict adherence to guidance about personal protective equipment, which included masks and respirators, compromised normal ward functioning in a UK hospital setting. 2 years later, a 2014 Danish systematic review of the mask-related scientific literature concluded, the studies unequivocally show that it does not have any effect on the incidence of postoperative infections whether the staff wears a mask or not. Even a systematic literature review favorable towards masks, and which only included one randomized controlled trial with masks as an intervention, was still forced to concede, in a turn of phrase worthy of the most brilliant marketers, that face mask use provided a non-significant protective effect against influenza viral infections. Would you pay money to wear a piece of armor with a non-significant protective effect? Would you pay for a drug with a non-significant therapeutic effect? A 2019 literature review of The Evidence Behind the Ability of Gloves, Masks, Gowns, Drapes, Head Covers, Footwear, and Ventilation Systems to Prevent Surgical Site Infections drew attention to the following anecdote. A study by Mullaney and Stevens suggested that mask use may reduce the incidence of postoperative hemolytic streptococcus wound infections to 5%. The practice of wearing masks during surgery subsequently became more widespread. Interestingly, the same authors refuted their initial findings 9 years later and reported infection rates with consistent mask use to be much higher than had been anticipated in their initial study. Recent studies comparing outcomes with or without surgical face masks have found little to no difference in surgical site infections. As part of their own 2019 randomized controlled trial, Wang and colleagues conducted an additional internal meta-analysis of previous randomized controlled trials. At this point, I'm sure you are shocked to find out that they too found a total lack of efficacy from masks to prevent influenza or influenza-like illness. The verdict based on the totality of evidence from randomized controlled trials did not change when Jefferson et al. Revisited it in a 2020 Cold Spring Harbor Laboratory meta-analysis. Compared to no masks, there was no reduction of influenza-like illness cases or influenza for masks in the general population nor in healthcare workers. Observational studies show masks do not work. There are also more than 40 observational studies covering situations from school districts to surgical suites, which on their own provide strong evidence that masks do not provide a statistically significant infection control benefit even for bacteria, much less for respiratory viruses such as COVID-19. Many of these were in schools. A 2022 observational study in North Dakota was practically a naturally occurring randomized controlled trial, comparing 2 adjacent school districts with a combined total of over 23,000 students and congruent population demographics which differed only on mask policies and covered a 5-month period overlapping both the Delta and Omicron waves of COVID. The authors concluded, "We observed no significant difference between student case rates while the districts had differing masking policies." Another analysis of COVID-19 case data from all 50 states over a 9-month period from June 2020 to March 2021 concluded, mask mandates and use are not associated with lower SARS-CoV-2 spread among U.S. states. Post-mandate growth curves for non-mandate states, early mandate states, and late mandate states were ultimately identical. A 2022 study by Chandra and Hogue replicated a highly cited 2021 CDC publication by Budzin et al. The CDC's study used data from school districts in 520 counties and purported to show a negative association between school mask mandates and pediatric SARS-CoV-2 cases from July to October in 2021. Chandra and Hogue's replicating study found that not only did the CDC's study end at precisely the best chronological stopping point to make the CDC's case that masks work, but when the period of time and school counties were extended to provide a broader, longer, more representative sampling of 1,832 counties, the CDC's results disappeared or reversed, even when still using the CDC's own methodology. Drs. Chandra and Hogue were polite but unambiguous. We replicated the CDC study and extended it to more districts and a longer period, employing 7 times as much data. Using the same methods and sample construction criteria as Budzin et al., but a larger sample size and expanded time frame for analysis, we failed to detect a significant association between school mask mandates and pediatric COVID-19 cases. While the presence of correlation does not imply causality, the absence of correlation can suggest causality is unlikely, especially if the direction of bias can be reasonably anticipated. Studies with significant findings are more likely to be published than those with non-significant or negative findings. This is particularly important in the context of the current pandemic, where publishing studies that fit a certain narrative can become a self-fulfilling prophecy rather than an unbiased pursuit of truth. Likewise, a retrospective study in Catalonia, Spain, comparing 3 to 11-year-olds, looked at over 599,000 children during the first trimester of the school year, September to December 2021, especially non-masked 3 to 5-year-olds compared with masked 6 to 11-year-olds. They found that the incidence of COVID correlated with age but not with masks. The authors reported, face covering mask mandates in schools were not associated with lower SARS-CoV-2 incidence or transmission, suggesting that this intervention was not effective. These results matched those obtained by a separate group of researchers the year earlier in the same Spanish province when evaluating school children from September to December 2020. These results are also consistent with those of a smaller 314-patient, 753 contact retrospective study of Catalonian Spanish households published in The Lancet Infectious Diseases in 2021, which reported that we observed no association of risk of transmission with reported mask usage by contacts, with the age or sex of the index case, or with the presence of respiratory symptoms in the index case at the initial study visit. A 2022 study in Finland by authors affiliated with the Finnish Institute for Health and Welfare, Department of Health Security, compared the COVID incidence among 10 to 12-year-olds in 2 Finnish cities, Helsinki, which did not have a school mask mandate for ages 10 to 12, and Turku, which did have such a mandate. Here, again, COVID numbers varied wildly at any given time, but when all was said and done, there was no net benefit to masking school children. According to our analysis, no additional effect seemed to be gained from this, based on comparisons between the cities and between the age groups of the unvaccinated children, 10 to 12 years versus 7 to 9 years. One would expect to see some differences in the age-specific incidences if masking was an effective way to control transmission in schools. A U.S. study which compared case rates in masked versus unmasked schools in Florida from October 2020 to April 2021 concluded, we do not see a correlation between mask mandates and COVID-19 rates among students in either adjusted or unadjusted analyses. Yet another retrospective study compared COVID outcomes of 35 European countries over the fall and winter of 2020 to 2021, from October 1, 2020 to March 31, 2021. Surprisingly, weak positive correlations were observed when mask compliance was plotted against morbidity, cases per million, or mortality, deaths per million, in each country. The positive correlation between mask usage and cases was not statistically significant, while the correlation between mask usage and deaths was positive and significant. These findings indicate that countries with high levels of mask compliance did not perform better than those with low mask usage. We will revisit this particular study at the conclusion of Part 2 when we talk about mask side effects. A 2023 observational study looking at U.S. data from all 50 states from January 2020 to July 2022 found that mask mandates were not associated with any difference in cumulative death rates. Though the authors reported a non-significant decrease in infection rates associated with mask mandates, even this was obtained only by excluding Omicron infections and by using IHME infection estimates arrived at via modeling. Moving on to observational studies on masks in healthcare settings, endophthalmitis is a bacterial infection of the tissue or fluids of the eyeball. It is a medical emergency, which can easily result in permanent blindness. A 2021 study reviewing 483,622 intravitreal injections, shots given into the fluid of the eyeball through the front of the cornea, found that physician face mask use did not affect the overall rate of post-injection endophthalmitis. There is no reason to think that masks will affect the transmission rate of a virus if they do not provide any statistically significant benefit against bacteria which are 10 times the size. These study findings also undermined the rationale for wearing goggles and face shields to stop COVID infections. These findings that masks do nothing go back decades. In 1980, surgeon Neil Orr discontinued the use of masks in a surgical ward in England and found no increase in wound infections compared with the previous 4 years. Dr. Orr reported his findings in the Annals of the Royal College of Surgeons. Nose and throat swabs were taken from all theater personnel monthly or when they had a cold. No restrictions in theater were imposed on talking, movement, beards, or colds. In fact, the theater routine remained unchanged except that no one wore a mask. Not only did infections in the hospital ward not increase, Dr. Orr actually reported an overall decrease in wound infections when mask use was discontinued. Moreover, the 8 infections which did occur bore no relation to the throat or nose cultures from the theater team. In response to inquiries, Dr. Orr subsequently confirmed that this decrease in infections was not due to any changes in antibiotic regimens, because antibiotic regimens did not change during the trial. In 1996, a 6-month prospective observational trial was conducted at the Sheffield Northern General Hospital in England, comparing the rates of post-surgical infection when the surgical team wore open face shields, visors, versus medical masks. Procedures performed this way included invasive thoracic surgeries. The researchers found a 3.1% postoperative infection rate in the face shield group, and a 4.4% postoperative infection rate in the mask group. This difference was not statistically significant, and is the opposite of what every COVID crisis theory supporting mask use predicted. Similarly, Ruthman and colleagues reported in the Illinois Medical Journal that no significant difference in emergency room infection rates occurred when laceration repairs were done with or without caps and masks over the course of hundreds of procedures. A 1994 seroepidemiological case control study of respiratory virus infections among dental surgeons in Wales found that dentists generally had a higher prevalence of antibodies to influenza than the general population. What the study did not find, however, was any benefit from masks. Wearing of masks or eye protection did not markedly reduce infection with these viruses among the dentists. A June 2020 survey of over 2,000 dentists published in the Journal of the American Dental Association found a mere 1% rate of COVID infection at the time, and did not note any differences in outcomes based on personal protective equipment between medium-risk dentists who wore respirator-type masks and high-risk dentists who did not wear both face masks and eye protection. In a 2021 study where dental treatment was performed on asymptomatic COVID patients, the authors reported that we also identified low copy numbers of SARS-CoV-2 virus in the saliva of several asymptomatic patients, but none in aerosols generated from these patients. The authors concluded that dental treatment is not a factor in increasing the risk for transmission of SARS-CoV-2 in asymptomatic patients, and that standard infection control practices are sufficiently capable of protecting personnel and patients from exposure to potential pathogens. A small study done in a Denver, Colorado pediatric hospital found gowning and masking did not appear to influence either illness or specific virus infection. A small 2009 study of hospital workers by Jacobs et al. In Japan found no difference in respiratory viral infection rates between the masked and non-masked study cohorts. A 2001 German study concluded that surgical masks worn by patients during regional anesthesia did not reduce the concentration of airborne bacteria over the operation field in our study. Thus, they are dispensable. A 2007 Saudi Arabian case control study conducted on 250 medical personnel treating Hajj pilgrims reported, in our study, regular use of face masks offered no significant protection against acute respiratory infection. Our finding is in agreement, however, with the conclusion of the Centers for Disease Control and Prevention in the USA, which stated that surgical masks are not designed for use as particulate respirators and do not provide much protection against airborne diseases because they do not effectively filter small particles from the air or prevent leakage around the edge of the mask when the user inhales. Furthermore, we found that intermittent use of surgical-type masks was actually associated with more than a 2.5-fold greater risk of infection. The study authors concluded, the common practice among pilgrims and medical personnel of using surgical face masks to protect themselves against acute respiratory infections should be discontinued. Another case control study of 254 healthcare workers published in 2013 examining the 2009 spread of H1N1 influenza in Beijing concluded, we were unable to demonstrate any impact of masks or hand washing in healthcare workers against pandemic influenza. A 2002 Danish study on the use of masks during percutaneous cardiac catheterization got the same results as a 1989 study which reported that caps and masks had no effect on postoperative infection rates and were unnecessary. In a 2003 case control study of 31 healthcare workers in a Toronto hospital who were exposed to the original SARS-CoV, half of the resulting 6 infections occurred among the 13 healthcare workers who reported always wearing some kind of mask, including the 6 who wore N95s, and 3 infections occurred among the 18 who did not always wear a mask. Only one of the infections occurred among the subgroup of 8 who took no precautions. Congruently, a 2003 CDC MMWR report described 9 to 11 other healthcare workers in Toronto who were all infected by SARS-CoV when treating the same patient, despite the fact that they all had worn the recommended personal protective equipment each time they entered the patient's room, including gown, gloves, PCM 2000 duckbill masks, and goggles with or without an overlying face shield. A 2004 retrospective study on the original SARS-CoV noted that of the 45 United States healthcare workers who had exposure to laboratory-confirmed SARS-CoV patients without any mask use during the course of a local outbreak, none were infected, despite the fact that an exposure was defined as any healthcare worker-patient interaction that occurred within droplet range, i.e. 3 feet. Conversely, a separate 2004 study out of Hong Kong found that almost 100% of 72 study respondents who contracted SARS-CoV had done so despite wearing N95 masks. Astute or hostile readers will note that the 4 studies just cited are consistent with masks not working, but that masks not working is far from the only possible explanation for these study results. To this I say, yes, I would not have even bothered to include such weak studies in this section if the CDC had not used even more studies of exactly this type to argue in favor of masking. Hold on to your criticisms of these studies and apply them even-handedly when we review the evidence put forward by the CDC to argue that masks work. Masks were not mandated on flights to Canada until April 15, 2020. On January 22, 2020, a 15-hour flight carried 350 mostly unmasked passengers and one man later determined to have been symptomatic with COVID-19 from Wuhan to Guangzhou, then Guangzhou to Toronto. Despite this extremely close contact and conspicuous lack of masks for more than half a day, the only other passenger subsequently found by nasopharyngeal and throat swabs to be positive for COVID-19 was the man's wife. On the other end of the spectrum, a November 2021 brief report in Clinical Infectious Diseases described multiple cases of SARS-CoV-2 transmission despite the carrier being masked, the exposed person being masked, or both persons being masked. On average, the highest risk setting for transmission of COVID-19 is within households, and 3 meta-analyses from 2020 and 2021, which included 54, 92, and 97 studies, respectively, found that the secondary attack rate averaged from 18% to 21%. 95% confidence intervals ranged from 16 to 24%. This is worth noting because a 2021 study of a COVID-19 Delta variant outbreak in an Israeli hospital found that despite a 96% vaccination rate and strict hospital-grade masking, the calculated attack rate among all exposed patients and staff was 10.6%, 16 out of 151 for staff, and 23.7%, 23 out of 97 for patients. In other words, the observed secondary attack rate of SARS-CoV-2 among fully masked and vaccinated patients was as high or higher than that observed in meta-analyses of intra-household transmission. Based on those cited above and other studies, multiple reviews of laboratory studies and the observational literature have come to conclusions like those of the randomized controlled trial reviews and meta-analyses cited earlier. A 1996 literature review published in the British Journal of Theatre Nursing said, "Current practices of operating room management and sterile technique are direct descendants of the elaborate principles of antisepsis and asepsis set down by Dr. Joseph Lister. The available clinical data suggests that the present generation of masks does not protect staff either from airborne bacteria or hepatitis B virus. It is now generally accepted that the wearing of masks for ward procedures is unnecessary. Some studies suggest that surgical face masks might actually increase the incidence of surgical wound infection by increasing the shedding of facial skin. Another hypothesis may be that by discarding masks, individual nasal and oral droplets might be more likely to atomize and remain airborne." Another literature review from 2001 in the journal Anesthesia and Intensive Care said, "A questionnaire-based survey undertaken by Leyland in 1993 to assess attitudes to the use of masks showed that 20% of surgeons discarded surgical masks for endoscopic work. Equal numbers of surgeons wore the mask in the belief they were protecting themselves and the patient, with 20% of these admitting that tradition was the only reason for wearing them. There is little evidence to suggest that the wearing of surgical face masks by staff in the operating theater decreases postoperative wound infections. Published evidence indicates that postoperative wound infection rates are not significantly different in unmasked versus masked theater staff. This continued into reviews in the 2010s. A 2014 literature review published in the Journal of Bone and Joint Surgery said, "Surgical masks have not been shown to reduce rates of surgical site infection in the operating room." A year later, another author, published in the Journal of the Royal Society of Medicine, wrote uncontroversially, "Overall, there is a lack of substantial evidence to support claims that face masks protect either patient or surgeon from infectious contamination." A living rapid review published in the Annals of Internal Medicine in 2020 and repeatedly updated until August 2022 stated, "Randomized trials in community settings found possibly no difference between N95 versus surgical masks and probably no difference between surgical masks versus no mask in risk for influenza or influenza-like illness." Even in the case of those observational studies which may suggest some benefit from masks, risk estimates were not statistically significant. The advent of SARS-CoV-2 did not somehow magically invalidate all the evidence on masks laboriously collected over the prior decades. Nevertheless, the political pressure for compulsory masking was so great that at least one article published in the journal Medical Hypotheses, which questioned the efficacy of masks, citing, among other things, the WHO's and CDC's own recommendations from early 2020, was retracted by the editors following backlash. Meanwhile, other far more deficient analyses promoting masking remained untouched. Multiple studies touted by the CDC to support mask wearing turn out to show the opposite on closer examination. For example, a 2020 population-based intervention with trend analysis by Van Dyke et al., published in the CDC's August 2020 MMWR, has been widely cited as evidence favoring the efficacy of face masks. The CDC leapt to put out a summary graphic which said, "Kansas implemented a mask mandate on July 3rd. Some counties opted out. In counties with a mask mandate, new cases per 100,000 people decreased 6%. In counties without a mask mandate, new cases per 100,000 people increased 100%. CDC recommends everyone aged 2 years and older wear masks in public." However, that is not what this study, dubbed the Kansas Mask Mandate Study, actually shows. In reality, over the 6-week period evaluated from July 3, 2020 to August 21, 2020, COVID cases in the mask mandate counties actually increased far more quickly than they did in the non-mask mandate counties. The numbers used were publicly available, and I personally looked them up at the source. The non-masked Kansas counties began the study period with almost double the COVID cases of the interventionist mask mandate counties, but finished the study period with almost the same incidence of COVID cases per 100,000 people. Over the course of the study period, COVID cases in the mask mandate counties increased almost twice as quickly as they did in the non-mandate counties. The non-mask mandate counties started the study period on July 3, 2020 with 825 COVID cases per 100,000 population and ended the study period on 21 August 2020 with 1,271 COVID cases per 100,000. The mask mandate counties began the study period with just 411 COVID cases per 100,000 population, but by 21 August had jumped almost twice as far to 1,262 cases per 100,000 population. The Kansas Mask Mandate study authors reached their presented conclusion that masks show viral spread by graphing a period of time where the rate of COVID acceleration, the change in the number of new cases, known as incidence, decreased slightly in the mask mandate counties, but was still increasing in the non-masked counties. Their conclusion says nothing about the actual total number of new cases of COVID in these counties, the velocity of COVID. Furthermore, as the study's own tables reveal, the Kansas counties that never mandated masks still ended the study with a lower overall COVID acceleration than the masked counties. Instead of being straightforward like Bundgaard et al.'s randomized controlled trial Danish mask study, the CDC's Kansas observational mask mandate study looked at the rate of change of COVID cases and then cherry-picked a time period to get the results that best supported their desired conclusion. If the Kansas mask mandate study authors had extended their study time period by just a week or two in either direction, they would have had to flip their conclusion, and as it is, they still could not completely hide the fact that the non-masked counties in their study did better overall. Far from providing evidence in favor of mask mandates, the data underlying the Kansas mask mandate study, if it does anything, actually provides evidence that mask mandates make things worse. The authors of a July 2020 CDC MMWR report evaluated SARS-CoV-2 transmission among nearly 600 overnight campers in Georgia, where cloth masks were mandated for the staff but not for the campers. The cloth-masked staff subsequently experienced the highest attack rate of SARS-CoV-2 infection, 56% compared to the campers' 33 to 44%, and the authors reported this striking observation while simultaneously asserting that cloth masks have been shown to reduce the risk of infection from COVID-19, citing only the CDC's MMWR Missouri Hair Salon No Control Group study to support that claim. More on that particular embarrassment later. Another CDC MMWR cross-sectional report surveyed 169 Georgia K-5 schools during the strikingly short and specific 4-week time period of November 16th to December 11th, 2020. Much of this paper was devoted to hypothesizing about why a statistically significant result for masking teachers and staff was observed, but not for students. The 21% lower incidence in schools that required mask use among students was not statistically significant compared with schools where mask use was optional, before conceding that the data from this cross-sectional study cannot be used to infer causal relationships. Another population-based intervention with trend analysis, which at the time of this writing is still cited by the CDC to support mask use, was conducted in the Massachusetts General Brigham Healthcare Network and published in the Journal of the American Medical Association. The study authors tracked SARS-CoV-2 PCR test positivity rates among the hospital healthcare workers from March 1st to April 30th, 2020. They observed that the percent of healthcare workers testing positive for SARS-CoV-2 declined after a universal mask mandate was imposed on all staff and patients in the hospital system on April 6th, and immediately assumed that masks were the cause. Unlike the Kansas mask mandate study, the Massachusetts General Brigham study lacks even the pretense of a control group, and relies entirely on chronological association. These fatal limitations did not prevent the authors from asserting, "We believe that our study provides definitive data on the value of universal masking in a healthcare setting during a pandemic, and that the results can be generalized to other settings even where social distancing is not possible." However, when the authors' findings are juxtaposed with publicly available data on COVID cases in Massachusetts as a whole during the same time frame, what we see is two epidemic curves that follow an identical course. They even peak on the exact same day, April 13th. Moreover, it becomes obvious that Massachusetts Governor Baker's later masking order, effective on May 6th, a full month after the hospital mandate, had no effect on the epidemic curve either. One might try to argue that the observed differences in SARS-CoV-2 test positivity rates between the Massachusetts General Brigham healthcare workers and Massachusetts general population, with the general population testing positive for COVID at a higher rate, should be ascribed to differences in personal protective equipment use. However, quite apart from the fact that masks were just one of many interventions aimed at stopping COVID imposed by the Massachusetts General Brigham Hospital system during this same time period, there are at least two strong factors which on their own are adequate to explain any observed difference in test positivity rates. First, the general population had double counting of cases. The Massachusetts General Brigham study authors eliminated duplicate positive results on the same person, whereas the Massachusetts Health Department did not do this. Second, we should expect the general population to have a higher positivity rate because the general population had a higher selection bias in favor of positive test results. During the time period studied, available tests were scarce. The hospital system had the resources to test all suspected cases among their employees, whereas the state as a whole could only test a small percentage. Thus, fewer of the less symptomatic cases among the general population were tested, which would produce a much higher overall positivity rate. Thus, far from being evidence in favor of mask efficacy, when placed into the proper context, the Massachusetts General Brigham Hospital study actually suggests that masks are not helpful. In 2023, another hospital masking study was presented at the 33rd European Congress of Clinical Microbiology and Infectious Diseases in Copenhagen, Denmark. This study did everything that the Massachusetts General Brigham mask study authors neglected. Instead of looking at less than 2 months of data, the UK researchers followed COVID-19 infections at St. George's Hospital in southwest London for 40 weeks, nearly 10 months in 2021 to 2022. The researchers compared the incidence of hospital-acquired Omicron COVID-19 infections when compulsory masking for staff and visitors was discontinued in the majority of wards at week 26 of the study period. The minority of wards which continued to require masks was used as a control group, and the researchers also compared the rate of COVID-19 in the hospital with that of the surrounding community. This later, longer, stronger study with multiple comparison groups found that the cessation of masking in hospitals was not associated with a statistically significant change in the rate of COVID-19 infections. We found no evidence that a mask policy significantly impacts the rate of nosocomial, hospital-acquired, SARS-CoV-2 infection with the Omicron variant. Laboratory studies show masks do not work. The bulk of citations to support the efficacy of masking are mechanistic laboratory studies, because they can be much more tightly controlled than real-world scenarios and examine one or two features of masks in isolation. Laboratory experiments by their nature are the most likely to find mask efficacy. However, even in this category of studies, there is an equal or greater weight of laboratory studies which call the efficacy of masks into question. By April 2nd of 2020, very early in the events surrounding COVID, a study published in The Lancet observed that SARS-CoV-2 remains viable for days longer on the inner and outer layers of medical masks than on wood, cloth, glass, stainless steel, or plastic. The study found that while SARS-CoV-2 remained viable for less than 3 hours on tissue paper and 1 or 2 days on cloth or glass, viable virus was recovered from the inner layer of medical masks after 4 days, and after up to 7 days on the outer layer. This supplemental information was publicly available and easy to locate. In 2008, surgical masks were tested using NIOSH standards, and the results were published in the American Journal of Infection Control. The study authors reported that none of the surgical masks exhibited adequate filter performance and facial fit characteristics to be considered respiratory protection devices. In 2013, a team of researchers studying the protective effects of surgical masks admitted live infectious virus was extracted from the air from behind all surgical masks tested. This suggests that influenza virus can survive in aerosol particles that are able to bypass or penetrate a surgical mask. Consistent with the real-world observations and randomized controlled trials cited earlier, which found that N95 respirators provide no statistically significant protective effect from respiratory viruses when compared with surgical masks, a 2022 laboratory study with a human subject using a bacteriophage virus as a proxy for SARS-CoV-2 conceded, even with the best-fitting N95 mask, there was still virus aerosol contamination of the nose after 45 minutes exposure to high virus aerosol load at close range in the absence of HEPA filtration. This should come as no surprise, because an earlier 2008 laboratory study had already found that N95 respirators perform at their worst when challenged by particles the size of a coronavirus. Coronaviruses range in size from 0.06 to 0.14 micrometers, 60 to 140 nanometers. The filter layer of N95 masks has an average pore size of about 30 micrometers, 30,000 nanometers or more, with the smallest pores still being at least 5 to 8 micrometers, 5,000 to 8,000 nanometers. Medical, surgical, cloth, and other types of masks perform even worse. The middle filter layers of medical surgical masks have larger, similar structures, but average pore sizes ranging from 10 to 33 micrometers, 10,000 to 33 nanometers in diameter. But importantly, this filter layer is about 1/2 to 1/4 the thickness of the filter layer in an N95. This is part of why surgical masks are easier to breathe through. In polyurethane or cloth masks, the pore sizes range from 100 to 500 micrometers, 100,000 to 500,000 nanometers. Suggesting that a respirator-type mask could protect against COVID was bad enough, but expecting a cloth or medical surgical mask to slow down a respiratory virus is like expecting a wall perforated with football fields to stop a barbarian horde. Such suggestions should never have been taken seriously. Even assuming the viruses are carried on larger microdroplets and aerosols, they still have more clearance passing through masks than cars driving down 6-lane freeways or mosquitoes flying through chain-link fences. Yet another 2013 experiment studying face masks as source control found that after just 2 hours of use, the bacterial counts expelled from cloth and medical face masks equaled or exceeded any initial reduction, and were on a trajectory to increase still further. The study did not examine counts beyond 2.5 hours. If masks produce this result with regard to bacteria, there is no reason to expect masks to perform better on viruses a fraction of the size. All these laboratory results are nothing new. Dr. W. H. Kellogg, MD, Secretary and Executive Officer of the California State Board of Health, observed that the masks, contrary to expectation, were worn cheerfully and universally, and also, contrary to expectation of what should follow under such circumstances, no effect on the epidemic curve was to be seen. Something was plainly wrong with our hypothesis. Even using a bacterium more than 10 times larger and thus far easier to filter out than SARS-CoV-2, Dr. Kellogg found that with the element of aspiration introduced, as in the natural use of masks, even 5 layers did not give a sufficient reduction in count to make such a mask of value. Dr. Kellogg was writing in 1920 about the Spanish flu, but his assessment is just as applicable to SARS-CoV-2 from 2020 to the present. One of the early lab studies on masks from 1975 was conducted in operating rooms using bacterial settle plates. The researchers were surprised to find that bacterial counts in the operating rooms were not influenced by the wearing of a face mask. As early as 1980, a team of researchers applied human albumin microspheres to the inner aspect of a surgeon's face mask before 20 major orthopedic procedures. The researchers were dismayed to find that microspheres were retrieved from the wounds in all 20 experiments, thereby demonstrating wound contamination by the particles. A 1992 Swedish study examining air counts of colony-forming units of bacteria over wounds during live surgeries found the same thing. The use of masks during operations does not influence the number of potentially pathogenic bacteria in the air close to the operation wound. Another 1991 laboratory study in a surgical suite tried to determine if unmasked volunteers could contaminate bacterial settle plates. The results? Oral microbial flora dispersed by unmasked male and female volunteers standing 1 meter from the table failed to contaminate exposed settle plates placed on the table. Further, volunteers were asked firstly to whisper and secondly to recite out loud with their mouths placed 15 centimeters from exposed culture plates for 5 minutes. A small number of colony-forming units of bacteria were found on settle plates situated on the operating table and the instrument tray when a volunteer recited out loud without a mask. There was no contamination when up to 4 volunteers recited together standing 1 meter from the table. The numbers of airborne bacteria expelled from the nose and mouth are insignificant compared with the substantial numbers shed from the skin. These observations suggest that oral bacteria normally conveyed in droplets into the air during ordinary talking by non-scrubbed staff who are not within the immediate vicinity of the operation site do not pose an infection hazard, and the wearing of masks is unnecessary. Despite long-standing and numerous findings like these, activities like singing were frequently banned in the name of infection control during the COVID crisis. A team of researchers in 2021 researching masks in the context of intravitreal ophthalmic injections found results that were congruent with the earlier studies. In both the no-talking and speech scenarios, subjects wearing a tight-fitting face mask without tape had the highest bacterial growth, similar to or even higher than not wearing any mask. It is possible that the tight-fitting face mask without tape may result in a greater amount of bacterial dispersion upward toward the subject's eye. Indeed, a recent study assessing respiratory droplet velocities with face mask use during simulated coughs reported that even with tight-fitting face masks, small openings can lead to leakage of droplets around the mask. These laboratory studies on masks combine to indicate that even under optimal conditions, which do not reflect mask use in the real world, masks make, at best, a debatable and negligible difference in bacterial counts, producing no significant net effect on postoperative infection rates. Again, if masks do not impede bacteria, there is no reason to think they will impede viruses which are less than 1/10 the size and mechanically far more difficult to exclude. A light microscopy and filtration study published in 2019 highlights just 2 of the mechanisms by which any protective benefit from cloth masks may be offset on net balance. Stretching and washing associated with normal wearing causes a cumulative and rapid decline in the filtration capability of cloth masks. In this study, the researchers washed cloth masks 4 times and found that each washing resulted in about a 5% decline in filtration efficacy. Importantly, this study also re-highlighted one of the primary mechanical features which makes a mockery of attempts to justify compulsory cloth mask use in the name of protection from a virus no larger than 0.14 micrometers. The pore size of masks ranged from 80 to 500 micrometers, which was much bigger than particulate matter having a diameter of 2.5 micrometers or less. The effects of washing cloth masks described in this 2019 study take on even greater significance in light of a 2020 study from a team of researchers testing cloth masks made according to the CDC do-it-yourself instructions for single and double-layer t-shirt masks. Wearing an unwashed single-layer t-shirt mask while breathing yielded a significant increase in measured particle emission rates compared to no mask, increasing to a median of 0.61 particles per second. The rates for some participants exceeding 1 particle per second, representing a 384% increase from the median no mask value. Wearing a double-layer cotton t-shirt mask had no statistically significant effect on the particle emission rate, with comparable median and range to that observed with no mask. In other words, the CDC instructions on how to make masks were useless at best. The observed particle emission rates of study participants during coughing and jaw movement were particularly noteworthy, with the non-masked condition performing far better than the CDC-designed cloth masks, comparable to the surgical masks KN95 and even some individuals wearing N95s. Additionally, the researchers elaborated on one of the mechanisms by which cloth masks may increase the incidence of infection above a non-masked baseline. They noted that their own previous work had established that aerosolized fomites, non-respiratory particles aerosolized from virus-contaminated surfaces such as animal fur or paper tissues, can also carry influenza virus and infect susceptible animals. This observation raises the possibility that masks or other personal protective equipment which have a higher likelihood of becoming contaminated with virus might serve as sources of aerosolized fomites. Even the mechanistic laboratory studies cited as evidence to support the efficacy of masks by the CDC's science brief, Community Use of Masks to Control the Spread of SARS-CoV-2, are not unequivocally favorable to masks, especially not to cloth masks. To support its masking recommendations, the CDC referenced a 2021 laboratory study of SARS-CoV-2, which reported that cloth and surgical masks were not significantly different in that both reduced viral RNA in fine aerosols by 48%. The CDC failed to mention, however, that the same study also reported that the face mask group had a greater number of infectious, culture-positive, fine aerosol samples than the non-mask group. None of the 75 fine aerosol samples collected while not wearing face masks were culture-positive. 2 of the 66 fine aerosol samples collected from participants while wearing face masks were culture-positive. The CDC referenced a 2020 laboratory study as evidence that singing increases the risk of transmitting COVID by increasing the amount of exhaled respiratory particles, but neglected to mention that the same study said SARS-CoV-2 could not be detected in the air samples collected while confirmed COVID-19 patients were singing and talking. Oh, really? You don't say. Another study referenced by the CDC in its science brief on masks, far from providing strong evidence to support cloth mask use, showed that cloth masks and other fabric materials tested in the study had 40 to 90% instantaneous penetration levels against polydispersed sodium chloride aerosols. This instantaneous penetration reached maximum 73 to 82% at 100 nanometers, coronavirus size. Multiple studies referenced to support cloth mask use by the CDC's science brief involve experimental setups which are impossible for mask wearers to duplicate under functional real-world conditions. Even under such unrealistically favorable conditions, at least one study reported the average filtration efficiency of single-layer fabrics and of layered combination was found to be 35% and 45%, respectively. That kind of efficacy is nowhere near enough to stop a virus. Another 2020 study, referenced in the CDC's science brief on masks, highlighted this deficiency. Publication of only the ideal filtration efficiency of materials in perfectly sealed settings can give mask wearers a false sense of security. Though referenced by the CDC science brief in a manner suggesting that it supports mask efficacy, Multiple layers of cloth with higher thread counts have demonstrated superior performance compared to single layers of cloth with lower thread counts, in some cases filtering nearly 50% of fine particles less than 1 micron. This 2020 laboratory study actually found that the filtration efficiency of loosely fitting masks, respirators, against ultrafine particles can drop by more than 60% when worn compared to the ideal filtration efficiency of the base material. The researchers found that when challenged by coronavirus-sized particles of 60 and 120 nanometers under conditions more closely analogous to the real world, the filtration efficiency of medical masks, KN95s, and even N95s was reduced to less than 20%, comparable to a basic number 4 coffee filter. Similarly, another laboratory study found that when just 2% of mask material's surface area was compromised, filtration efficiency declined by over 2/3 of the material's maximum. These measurements showed that already very small leaks in the order of 1% of the total sample area can substantially reduce the overall filtration efficiency of a mask down to half or even less compared with the value of the material itself. Simple visual inspection reveals that non-respirator masks have more than 4 to 5 times this amount of leakage. Additionally, the category of particle sizes used even for this study, less than or equal to 2,500 nanometers, was many times larger than that of SARS-CoV-2 140 nanometers, and would still tend to overestimate mask effectiveness against respiratory viruses. Expert opinions, modeling studies, and qualitative and conceptual literature reviews predict that masks do not work. Political claims that the science is settled in favor of masks, or that all experts agree masks work, were false from inception. Pagan priestly divinations using the entrails of sacrificial animals have a better track record of accuracy than COVID-19 modeling studies, and when it comes to expert opinions, many experts and professional bodies have still been willing to oppose compulsory masking despite the political stigma that came with doing so. A handful of examples are presented here for the sake of completeness. Even or especially in healthcare settings, pronouncements on the dubious virtues or outright ineffectiveness of masks as infection control measures go back decades, especially in Scandinavian countries. As a 1993 expert opinion published in a Danish medical journal put it, there is therefore no reason from the point of view of preventing infection to maintain a general requirement for the use of surgical masks by others than those persons who may be situated within an arm's length of the operational field or instrument table. In 2010, Swedish authors from the Karolinska Institute noted with satisfaction that anesthesia personnel are no longer required to wear disposable face masks in the operating room, a practice approved by our surgical colleagues. Early in 2020, the Journal of Pediatrics and Child Health published a letter with 8 signatories from departments of infectious diseases and microbiology stating that there is no good evidence that face masks protect the public against infection with respiratory viruses, including COVID-19. In August 2020, a Belgian MD, PhD, and honorary full professor at the School of Public Health publicly opined that it would appear that abstaining will often be more effective than wearing any mask without discernment. German MD Dr. Günter Kampf wrote a letter to the editor published in the November 2020 Proceedings of the National Academy of Sciences, pointing out that data from Germany indicate that mandatory face masks in shops and public transport as a single measure did not accelerate the decline of new cases. Even a published opinion which argued for the community use of face masks by the general public admitted that the benefits of doing so were debatable and ran against the vast majority of official guidelines and recommendations going back decades prior to 2020. In a legal context, the Association of American Physicians and Surgeons, AAPS, states in the strongest terms, the CDC mask mandate lacked medical justification and cannot withstand a merely cursory logical or scientific analysis. Likewise, America's frontline doctors said, it is the overwhelming weight of the available scientific and medical studies made on the subject of the wearing of masks that masks simply don't work. Affirmative evidence for the negative. If masks were effective at decreasing the spread of respiratory viruses, we would expect to see a preponderance of the best scientific studies consistently finding clear and convincing evidence of benefits against respiratory viral transmission from mask use. Instead, a thorough survey of the scientific literature, including independent systematic literature reviews and meta-analyses of multiple randomized controlled trials involving mask use, consistently reveals clear and convincing evidence of no benefits. Additionally, those studies purporting to show that masks mitigate the spread of respiratory pathogens, especially viruses, are, on average, smaller, shorter, weaker, less rigorous, and less numerous than studies which show no benefits from wearing masks. A printable poster-sized PDF chart depicting this evidential disparity, including all the studies cited by the CDC in its science brief, Community Use of Masks to Control the Spread of SARS-CoV-2, and The Science of Masking to Control COVID-19, can be viewed and downloaded for free at www.thebookonmasks.com/extras. One or two studies indicating non-efficacy for masks may be an anomaly, but more than 100 studies from dozens of researchers working independently in multiple countries over multiple decades is a decisive trend. As Drs. Ambarish Chandra and Tracy Beth Hogue put it, while the presence of correlation does not imply causality, the absence of correlation can suggest causality is highly unlikely, especially if the direction of bias can be reasonably anticipated. This is not simply a lack of evidence that masks work. This is a repeated and long-standing pattern of positive evidence that masks do not work, and it is cumulatively far stronger than the whole body of evidence from 2020 to the present, which has been put forward by officials and organizations with a conflict of interests in their increasingly desperate attempt to justify their mask mandates. If masks were actually effective at mitigating the spread of respiratory viruses and other pathogens, this abundance of negative findings and conspicuous shortage of positive findings would be reversed. The evidence supporting face mask use is not enough to surmount even the empirical hurdles, much less the moral and legal hurdles necessary to justify mask mandates. But what about the evidence supporting masks? Most of the time, instead of acknowledging, addressing, or attempting to rebut evidence like that which we just reviewed, apologists for mask mandates merely make broad or indirect references to CDC publications, recommendations, and guidelines to justify their positions, actions, and coercive mandates. The CDC's flagship publication supporting mask use is its science brief, Community Use of Masks to Control the Spread of SARS-CoV-2. At the time of this writing, it was last updated on December 6, 2021, to include a total of 90 references that give a first-glance impression of evidential strength. Anyone who has actually read the studies the CDC cites in its science brief, however, knows otherwise. The evidence base put forward by the CDC to justify mask recommendations and mandates is shockingly, inexcusably weak. The CDC has acknowledged only a handful of studies from the peer-reviewed literature cited in the previous section. Instead, it proffers a body of evidence to support its mask-related recommendations and directives that is far smaller, far weaker, and fails to hold up under even mediocre cross-examination. Dissecting the CDC's science brief on masks. Many of the references provided by the CDC in its science brief on masks do not even address the efficacy of masks to mitigate the spread of respiratory viruses. 33 of them, more than a third, fall into this category. These 33 out of the CDC's 90 science brief citations provide additional background evidence and information which might support mask use if masks work, but they do not themselves provide evidence that masks work. In fact, 11 of these 33 references actually provide evidence that would discourage the use of masks even if they worked. We will discuss many of these in more detail in the section on mask side effects, but for now, let's take a quick look at each of these 11 studies cited by the CDC in turn, and you can decide for yourself whether they favor or discourage the use of face masks. One, which we looked at earlier, noted that SARS-CoV-2 could not be detected in the air samples collected while confirmed COVID-19 patients were singing and talking. Another of these studies was published in the British Journal of Sports Medicine and reported, "Our data indicate that wearing a cloth face mask significantly impaired participant performance during a cardiopulmonary exercise test. The observed significant differences in key performance variables, i.e. reduced exercise time, physiological variables, e.g. VO2 max, maximum oxygen consumption, VE, minute ventilation, HR, heart rate, SpO2, oxygen saturation, and perceptual variables, i.e., rating of perceived exertion, dyspnea, suggest that exercising while wearing a cloth mask negatively impacted the exercise performance of our sample. A 2020 study using healthy male volunteers reported that assessment of the hemodynamic parameters showed that FFPM, FFP2/N95 masks decreased AVDO2, arteriovenous O2 content difference, by 16.7% compared to no mask. The masks showed a marked effect on pulmonary parameters. Minute ventilation for both surgical masks and FFP2 N95 masks was significantly reduced by 12% and 23.1%, respectively, compared to no mask. Yet another of these studies reported wearing a treatment mask during the realization of a TM6, 6-minute walking test, does not modify the distance traveled but significantly and clinically increases dyspnea, the sensation of difficulty breathing. A study on the population most optimally able to tolerate masks, healthy male volunteers in their mid-20s, reported, in the healthy young men, age 25.7, in this study, the use of surgical masks was associated with a significant increase in airway resistance, reduced oxygen uptake, and increased heart rate during continuous exercise. Another study referenced by the CDC documented how face masks impair nonverbal communication by hampering viewers' ability to read and recognize emotions. This effect was especially pronounced in younger children tested using pictures of masked faces. For all age groups, the percentage of correct responses is significantly reduced for the images with face masks compared to the images without face masks. The performance of toddlers is more affected by the use of a mask than the performance of both older children. 4 of these 11 studies concerned skin damage from masks. We shall look at all of these and more in greater detail when we cover the side effects masks have on skin. A research letter reporting on a survey of more than 1,200 members of the general population in Thailand found that many experienced new skin disorders or the exacerbation of pre-existing skin disorders when wearing masks, and only 1/3 reported wearing their masks comfortably. A systematic review and meta-analysis of 35 dermatological studies by Spanish researchers reported that the rate of cutaneous adverse events related to mask use was over 50%, that 42% of children who used masks experienced irritant contact dermatitis, and that, in addition, 5 studies evaluated skin barrier function impairment due to mask wearing. A study conducted in Korea also reported cutaneous adverse events related to mask use in excess of 50%, and in patients with pre-existing dermatoses, the prevalence of skin lesions induced by wearing facial masks was 71.31%. A cross-sectional survey on healthcare workers out of England reported more than half of the participants, 454 cases, 54.5%, reported at least one adverse skin reaction related to a face mask. The other 22 background studies cited by the CDC in its science brief seek to address peripheral objections rather than to make a positive case for mask use based on efficacy. The information in these studies has value, but does not provide any actual evidence that masks work. Rather, they constitute evidence which could favor mask use if masks work. Additionally, when closely examined, most of these 22 references are hardly unequivocal endorsements of mask use. 3 studies showed that with intensive therapy and effort over multiple weeks, many autistic children can be trained not to rip off their masks or saturate them with saliva for short periods of up to 15 to 30 minutes. 2 more studies discussed how face masks affect people's ability to read and recognize emotions in a neutral or positive light. A 2020 study found no statistically significant differences between children's ability to accurately read emotions with or without a face mask, whereas another 2020 study documented that masks and sunglasses both significantly decreased children's abilities to accurately read emotions, but opined, while there may be some challenges for children incurred by others wearing masks, in combination with other contextual cues, masks are unlikely to dramatically impair children's social interactions in their everyday lives. 3 laboratory studies dealt with the effect of different activities on respiratory droplet generation. Expiratory human activities such as breathing, coughing, sneezing, or laughing result in droplet generation, and speech or simple breathing could be a potent yet until recently unsuspected transport mechanism for pathogen transmission. Increases in speech volume increase the rate, but not the size distribution, of particles emitted during speech. None of these three studies actually provide direct evidence about whether or not masks mitigate the transmission of respiratory pathogens. At best, they provide as much empirical justification for no-talking mandates in the name of infection control as they do for mask mandates, and do nothing whatsoever to surmount the moral barriers associated with attempting such a thing. Another study simply surveyed perceptions about mask use. A small but non-negligible proportion of children reported discomfort and side effects that should be considered to ensure high adherence to mask wearing among schoolchildren. The CDC Science Brief's overview of the respiratory and cardiovascular side effects of masks is curated to make the strongest case that these side effects are mild and acceptable. It is, at best, an incomplete survey of the literature on this subject, and we will make the counter case in Part 2 of the book on masks, going into detail on many studies left out of the CDC's analysis. Here, we will simply review the studies on this topic cited by the CDC in its science brief. Patients in a pediatric acute care unit were able to maintain full oxygen saturation without changes in end-tidal CO2, peripheral oxygen saturation, respiratory rate, and heart rate when supplemental oxygen was administered through their masks. The CDC science brief referenced this study as though it somehow supports long-duration mask use by children in other settings. The CDC characterized a 2020 Italian study of masking children by saying, "A separate study observed no oxygen desaturation or respiratory distress after 60 minutes of monitoring among children less than 2 years of age when masked during normal play." While technically truthful, this summary is misleading. The children were indeed monitored for 60 minutes, but only actually wore the masks for 30 minutes of the 60-minute monitoring period. Another study cited by the CDC likewise noted that children can wear masks for 30 minutes without sustaining significant changes in heart rate or oxygen saturation. As we shall see in Part 2, heart rate and oxygen saturation are both fairly resistant to changes from increased levels of carbon dioxide. According to the CDC, studies of healthy hospital workers, older adults, and adults with chronic obstructive pulmonary disease reported no to minimal changes in oxygen or carbon dioxide levels while wearing a cloth or surgical mask either during rest or moderate physical activity. The 5 studies cited by the CDC to support this broad conclusive assertion involved short durations of mask wearing for up to 60 minutes by healthy subjects. In one of these 5 studies, condominium residents in their 70s, excluding those who had comorbid cardiac or respiratory conditions that could lead to dyspnea or hypoxia at rest, were able to maintain full peripheral oxygen saturation for an hour while wearing the lightest type of disposable non-medical 3-ply face masks when at rest. Another one of these 5 studies reported that a small yet statistically significant difference in end-tidal carbon dioxide increase was observed while wearing a mask during a 5-minute walking test. End-tidal carbon dioxide is the amount of carbon dioxide in exhaled air. The remaining 3 studies in this cluster of the CDC's citations included findings that undercut conclusions about masks having acceptably mild side effects. After testing the most resilient group of subjects available, healthy, non-smoking, young adult males who routinely exercised, one concluded, short-term, moderate strenuous aerobic physical activity with a mask is feasible, safe, and associated with only minor changes in physiological parameters, particularly a mild increase in end-tidal CO2. The increase in end-tidal CO2 may be explained by the fact that rebreathing of the expired air which remains within the mask practically increases the dead space and may contribute to a mild hypercapnia. Another was a German study of trained 11-year-old boys, which reported that, at the maximum performance level with surgical face mask, there was a significant reduction in running time as well as a significant increase in the subjective perception of exertion. This study was cited by the CDC to support its science brief's broad assertion that the safety of mask use during low to moderate levels of exercise has been confirmed in studies of healthy adults and adolescents. The 5th exercise study cited by the CDC was conducted in 2012, again on healthy subjects in their 20s. The authors wrote, "Surgical mask use for 1 hour at a low-moderate work rate is not associated with clinically significant physiological impact or significant subjective perceptions of exertion or heat." The changes dismissed by the authors as not being clinically significant included statistically significant increases in heart rate 9.5 beats per minute, respiratory rate 1.6 breaths per minute, and transcutaneous carbon dioxide 2.17 mmHg. The CDC's science brief on masks characterizes these short-duration tests in young, healthy individuals as covering most circumstances. In doing so, the CDC is being as selective with reporting these background studies as it is with studies which directly evaluate mask efficacy. J. A. Schumpeter said that the first thing a man will do for his ideals is lie. It is not necessary to lie, however, in order to deceive, when filtering will accomplish the same purpose. Thomas Sowell, Intellectuals and Society, 2011. What about the CDC science brief's remaining 57 references? 11 of the CDC science brief's remaining 57 references were cited in our review of the evidence against masks because upon close examination, their results directly contradict the idea that masks are effective at mitigating respiratory virus spread. We also addressed Abuluk et al.'s Bangladesh mask study, which, even if taken at face value, still found no statistically significant benefit from cloth masks, meaning that the CDC's own best evidence for masks still invalidated virtually every mask mandate in the United States. Of all scientific evidence, modeling studies, especially those based on speculative data, are the most prone to bias and manipulation. Such sources do not and cannot provide enough warrant to justify mandates. Nevertheless, 5 of the remaining references in the CDC's science brief are comprised of just such sources. Fully 22 of the remaining studies are mechanistic laboratory studies. These studies suggest that masks should decrease viral spread, but offer virtually no real-life evidence that they actually do so. If theories, models, and laboratory studies say something should work, but real-life observations and randomized controlled trials fail to confirm this, then the models and laboratory studies are clearly missing critical pieces of the puzzle. Successful use of a mask as a barrier for droplets large enough to be observed with the unaided eye does not necessarily imply that masks also stop infectious particles too small to be seen. Suggesting anything else is showmanship, not science. Many of the laboratory studies cited by the CDC use photographs or video showing masks, as often as not on mannequins, stopping or curtailing the spread of droplets large enough that they can be seen by the naked eye, sometimes assisted by lasers, thermal imaging, or other techniques. Such laboratory studies persuade through implication and unstated appeals to audience intuition. They ignore the crucial fact that infectious viral particles are so small that they cannot be seen with the naked eye, which makes direct photography at best an illustrative analogy rather than decisive evidence of effectiveness. Citing to such studies is akin to showing that a common window screen can stop insects, and then claiming that window screens also meaningfully prevent air exchange, when in fact the entire point of using such a filter is to stop the large particles while letting the smaller ones pass through unimpeded. Conversely, however, if masks fail to stop emissions large enough to be seen with the unaided eye, this is evidence that they do not stop particles which are measured in nanometers. Laboratory studies purporting to show that masks filter microscopic particles often fail the applicability test as well. Simply looking at the experimental setup for many of these studies shows that while they may accurately describe the filtration properties of mask materials under optimal conditions, they are next to useless when describing real-world scenarios with masks. Many of these are pictured here, and none are accurate proxies for real-world mask use. As we covered earlier, this fatal deficiency was highlighted by a 2020 study which showed that under conditions far more akin to the real world, even surgical and respirator-type masks perform about as well as semi-transparent coffee filters. It takes a great deal of speculation, extrapolation, and chutzpah to parlay the laboratory studies cited by the CDC into recommendations, never mind mandates. Similarly, laboratory studies on improving mask fit or seal which are cited by the CDC to support mask use simply assume that the fit and filtration improvements described make a clinically or statistically significant real-world difference. The same applies to their laboratory study which reported that double masking improves filtration efficiency by 10 to 15% depending on which combination of masks is used. The dozens of observational and randomized controlled trials which we reviewed earlier have found that this underlying assumption, i.e., that improved or better sealed masks equals improved infection control, is not borne out by real world experience, even or especially in healthcare settings. If going from a medical mask to a fitted N95 produces no clear and convincing benefits in controlling respiratory virus transmission, there is no good reason to think using an overlay of nylon hosiery to give a better fit to your surgical mask will do so in the way the CDC's study citations suggest. What about the CDC Science Brief's real-world studies? After more than 2 years of motivated effort, the CDC's flagship science brief managed to scrounge up a mere 22 real-life studies on mask effectiveness that purportedly provide a scientific basis sufficiently robust to justify mask mandates. However, even light interrogation of these remaining studies reveals crippling deficiencies. 3 of these we have already dealt with in detail: the Kansas Mask Mandate Study, the Massachusetts General Brigham Mask Study, and the Bangladesh Mask Study. The Kansas Mask Mandate Study and the Massachusetts General Brigham Mask Study in particular so outrageously misrepresented the implications of their results and underlying data that insofar as they constitute any kind of evidence at all, they are most accurately characterized with studies providing evidence that masks do not work. 8 of the CDC's remaining 19 studies cited in its science brief are what the CDC euphemistically calls population-based intervention with trend analysis. In other words, post hoc ergo propter hoc. After this, therefore, because of this. A rain dance could accurately be called a weather-based intervention with trend analysis. Rain dances look especially effective when the investigator forces people to do a rain dance every day of the year and then confines their analysis to the rainy season. This is what the CDC is repeatedly guilty of doing with regard to mask evidence, engaging in statistical obfuscation and chicanery rather than objective scientific investigation seeking to find truth. All 8 of these studies have one or more glaring deficiencies that made them unable to serve as the basis for a definitive recommendation, much less a mandate, by any informed public official of good conscience. The July 1st to September 4th, 2021 school study by Budzin et al., published in the CDC's MMWR, was, as the authors stated, an ecologic study, and causation cannot be inferred. As pointed out earlier, when the study was later replicated and extended by Drs. Ambarish Chandra and Tracy Beth Hogue, any and all benefits of mask mandates completely disappeared. Drs. Chandra and Hogue were too tactful to say this directly, but I have no such compunctions. The CDC authors carefully and deliberately chose which dataset they analyzed in order to get the result the CDC wanted for political reasons. Another CDC MMWR study looking at COVID case and death rates from March 1st to December 31st, 2020, reported that mask mandates were associated with a less than 2% decrease in the case and mortality growth rates. Apart from the minuscule observed effect of masks, this CDC MMWR study includes the 3-month period prior to June 2020, when overall test capacity had not reached the threshold for effective contact tracing and stopped less than halfway through the winter season. The same deficiencies described above are magnified by a smaller selection of states and an even shorter time period in another CDC MMWR report that looked at just 10 states: California, Colorado, Connecticut, Maryland, Michigan, Minnesota, New Mexico, New York, Ohio, and Oregon from March 2020 to October 2020, and which associated decreased hospitalization rates with statewide mask mandates. As you can see in the accompanying chart, this study was published in February 2021, but completely excluded the much higher COVID peaks in November through January in all 10 of these states, which the draconian mask mandates did nothing to stop, and of which the authors could not have been unaware. The same applies to the CDC-cited study which used data from just 15 states and Washington, D.C. over less than 6 weeks, from April 8th to May 15th, 2020, to conclude that masks work. Compare and contrast these 2 studies cited by the CDC with just one of those we covered earlier. Unlike the CDC's citations, Guerra et al. Looked at the data on all U.S. states during the much longer period from June 2020 through March 2021, and encompassed the whole first winter wave of COVID, but found not even a small benefit from masks. Moving on, the CDC's science brief cites Galloway et al.'s study, published in a 2020 CDC MMWR, as strong evidence of beneficial changes in COVID-19 case rates in Arizona associated with mask use and other measures. The study authors themselves, to their credit, directly pointed out that the relationship between mitigation measures and changes in case counts are temporal correlations and should not be interpreted to infer causality. A simple visualization of the study time period in chronological context is enough to discredit any inferences of beneficial causality from masks in this sort of CDC study. Another CDC MMWR, published in September 2021, looked at Arizona schools in Pima and Maricopa counties over a mere 45-day period from July 15th to August 31st, 2021, and claimed to find that, after adjusting for potential described confounders, the odds of a school-associated COVID-19 outbreak in schools without a mask requirement were 3.5 times higher than those in schools with an early mask requirement. Yet this particular study does not even look at overall case numbers, but instead compares the number of schools with 2 or more cases. This means that schools with 2 cases or 200 cases get counted the same in determining the results. Neither does this study report the raw numbers of students and staff with COVID-19 infections which were traced to school spread, nor does it account for staff member vaccination rates. Furthermore, in this study, the CDC contact tracing guidelines themselves introduced a confounder, because CDC policy followed by the schools was to not even consider masked students as close contacts, effectively stacking the deck in favor of masks from the get-go. This leads to primary cases of COVID being overreported in the unmasked districts and secondary cases being underreported in masked districts. Another population-based intervention with trend analysis, still cited by the CDC, looked at data from 183 counties from January to May 2020 and concluded that masks were negatively associated with COVID-19 mortality. This is in contrast to a study we have already mentioned, which found that masks were associated with an increase in COVID deaths after evaluating a much longer, better documented time period. Similarly, another study which the CDC cited in its science brief, entitled "Face Masks Considerably Reduce COVID-19 Cases in Germany, a Synthetic Control Approach," used nothing more than temporal association and the total lack of a real control group to claim that the fall almost to zero in new infections after face masks were mandated in Germany between April 1st and April 10th, 2020 was attributable to mask use. This ignored multiple critical variables, including the fact that cases had already started decreasing across all of Germany from April 2nd, 2020. If it is fair game for the CDC to anchor its evidence favoring masks in chronological association with no control group, then it is more than fair to rebut it by pointing out that fanatical German mask mandates, including a medical mask mandate, had no effect on COVID spread in Germany at any time thereafter. This is extensively documented, especially by Ian Miller in his Substack and excellent book, Unmasked: The Global Failure of COVID Mask Mandates. These are essential mask-related reading with a great deal of original analysis and illustration. Additionally, subsequent excess mortality numbers for 2020 and 2021 published by the World Health Organization showed that Sweden, unmasked and not locked down, ranked near the bottom of excess European mortality for 2020 to 2021. Nevertheless, authorial disclaimers and fatal deficiencies have not stopped the CDC from citing the above 8 studies, 6 of which were published by the CDC itself, as strong evidence for a causal relationship between mask usage and lower transmission of COVID. It takes a special kind of brazenness to cite studies like this as evidence of mask efficacy powerful enough to justify mandates. This leaves just 11 remaining references in the CDC's mask science brief which we have yet to review. These consist of 1 meta-analysis of observational studies, 2 literature reviews, 4 retrospective observational studies, 2 retrospective cohort studies, 1 case control study, and 1 cross-sectional study, 4 reports of surveillance data. Chu et al.'s meta-analysis of observational studies, published in June 2020 in The Lancet, is possibly the strongest study put forward by the CDC to support mask efficacy. The authors combined the results of 29 observational studies, 7 MERS, 18 SARS, and 4 COVID-19. The studies had a combined total of 3,686 masked participants with 163 infections and 6,484 unmasked participants with 546 infections. The authors calculated that masked individuals have a 3.1% risk of infection versus 17.4% when unmasked. This generated a prevalent media soundbite that unmasked people were 5 times more likely to catch COVID than those that wore masks. Even if many other studies, experience, and observations since 2020 had not shown that calculation to have completely failed the test of reality, it was one meta-analysis of observational studies, did not include a single one of the randomized controlled trials we looked at earlier, and even the authors rated their findings low certainty. Also, it failed to include many observational studies which we reviewed earlier. The 2 remaining literature reviews cited in the CDC science brief are principally concerned with using a survey of existing literature to theorize about the potential effectiveness of cloth masks to stop viruses. Both rely primarily on laboratory filtration studies, but occasionally reference real-world studies such as McIntyre's 2015 study comparing cloth masks to medical masks. The same McIntyre 2015 study we looked at earlier, which said, "This study is the first randomized controlled trial of cloth masks, and the results caution against the use of cloth masks." The first of these 2 literature reviews is principally concerned with the decontamination of cloth mask materials, and discusses 4 filtration mechanisms: electrostatic filtration, diffusion, interception, and impaction. The second focuses on summarizing 25 laboratory studies of cloth filtration efficiency, including the material, weave, thread count, testing methodology, aerosol used for testing, aerosol size, and flow rate. Neither of these provides good evidence that cloth masks stop viruses or bacteria. As for the 2 retrospective cohort studies, as usual published by the CDC MMWR, one was conducted using PCR testing among a convenience sample of 382 service members from the USS Theodore Roosevelt in April 2020. The study authors found that service members who reported taking preventative measures had a lower infection rate than did those who did not report taking these measures, e.g., wearing a face covering, 55.8% versus 80.8%, respectively. The other retrospective cohort study cited by the CDC was conducted by phone interview among 335 people in 124 families in Beijing from February 28th to March 27th of 2020. The authors reported that mask use was 79% effective in preventing secondary transmission of SARS-CoV-2 within a household, and that daily use of chlorine or ethanol-based disinfectants was 77% effective. The authors also reported that wearing a mask after illness onset of a family member was not significantly protective. The case control study cited by the CDC compared the characteristics of 211 cases of COVID-19 with those of 839 matched controls in Thailand from April 30th to May 27, 2020. 48.6% of the COVID-infected group reported not having worn a mask, whereas 60.7% of the matched uninfected case controls also reported not wearing a mask. Yes, you read that right. A higher percentage of the uninfected group in this study reported not wearing a mask. But the CDC still cited this as evidence masks work because a higher percentage of the uninfected group also reported always wearing a mask. A much larger percentage of the infected group than the uninfected group reported wearing a mask sometimes. These 3 references in particular serve to highlight the CDC's outrageous double standard when it comes to evidence regarding masks. The CDC attempts to dismiss the results of the Danish face mask randomized controlled trial by saying the study was too small, i.e. enrolled about 0.1% of the population, to assess whether masks could decrease the transmission from wearers to others. Yet in the same science brief, the CDC claims that masks are effective based on shorter, uncontrolled studies from Thailand, China, and an aircraft carrier, which together have a combined total of less than half the number of participants as the Danish face mask study, and are orders of magnitude smaller relative to the populations of their respective countries. The cross-sectional survey study is primarily a modeling study using survey data collected over 8 weeks from June 3rd to June 27th, 2020. Again, compare and contrast this with the non-modeling studies cited earlier, covering case and death data over the course of more than 9 months across the United States and encompassing an entire winter flu season. Compare this also with any of the large-scale school studies showing no benefits from masking. The assortment of 4 reports of surveillance data are just as bad, if not worse. The infamous hair salon contact tracing study from May 2020 totally lacked a control group. Half of the contacts were not even tested, 35 were not contacted, and 37 outright refused testing and were self-reporting during a time when people had strong incentives not to report themselves being sick because of quarantine and isolation expectations. Using this hair salon surveillance report as any kind of proof that masks prevent viral transmission is as bad as claiming that not wearing masks has a protective effect based on surveillance studies with the original SARS, which we highlighted earlier, where 45 United States healthcare workers who had exposure to laboratory-confirmed SARS-CoV patients without any mask use were not infected. This hair salon study leaves many important questions unanswered, as Dr. Scott Atlas emphasized in 2021. No other stylists working with the 2 infected hairstylists, Stylist A and Stylist B, all mingling without masks, developed COVID symptoms. Did they catch the infection? None were tested, so we don't know. Close at-home contacts of Stylist A became infected, but the 2 close at-home contacts of Stylist B did not develop COVID. Perhaps that implies that Stylist B was simply not a spreader of the infection, regardless of mask wearing. Similar to one of the CDC MMWR reports looked at earlier, and using much the same data, a June 2020 Goldman Sachs research analysis argued that mask use was associated with a decline in the growth of COVID cases and deaths of up to 3.7 percentage points. The study predicted that widespread mask use would prevent a 5% drop in GDP and substitute for renewed lockdowns. Wrong on all counts. The third of these surveillance studies merely catalogs the published airline flights where secondary transmission of SARS-CoV-2 is believed to have occurred based on contact tracing. 3 mass transmission flights without masking are contrasted to 5 with strict masking. The utility of the study is limited because any potential control group of unmasked flights was eliminated by airline mask mandates early in 2020, and as we have already seen, spending 15 hours on a plane near someone who has symptomatic COVID-19 was not necessarily enough to catch it even from the beginning, when natural immunity was at its least common. Additionally, after the CDC's travel mask mandate was struck down in April 2022, there was no increase in COVID-19 infections on airplanes. The last of this cluster of studies was simply a report on the results of surveillance contact tracing of in-school transmissions of SARS-CoV-2 in 8 Massachusetts K-12 public school districts during the 2020 to 2021 school year. The study authors reported that 435 index cases of COVID-19 produced just 29 possible or probable in-school transmissions despite having 1,771 school-based contacts. The CDC science brief highlights that the study authors found an unadjusted secondary attack rate of 11.7% for unmasked versus 1.7% for masked interactions. Apart from the fact that this study leaves out roughly 280 other Massachusetts school districts, masks were mandated in Massachusetts schools throughout the study, so once again the CDC has built a crucial room of its evidential house on a study using no real control group. As the study authors themselves pointed out, notably, all reported classroom exposures were masked, so these results do not directly inform the impact of masking within classrooms. What about other studies not cited in the CDC science brief? Other studies supposedly showing the efficacy of masks fare no better. A 2022 literature review by Alisson et al. Was widely touted as evidence in favor of masks. German Federal Minister of Health Karl Lauterbach tweeted, "For everyone who is still unsure whether masks protect against COVID, here is a new American mega-study that evaluates over 1,700 studies. The benefit of the masks is very large, undisputed, and applies to many areas." Dr. Matthew K. Winia, MD, Masters in Public Health, Director of the Center for Bioethics and Humanities, who we will meet again in Part 4, also cited this study as evidence in favor of mask wearing. What Lauterbach neglected to mention was that the preprint study in question found over 1,700 studies in its initial search engine pass looking for evidence, but it only included 13 of them in its actual analysis. Anyone who cited this particular study as a serious reference supporting mask use or mask mandates forfeited any claim to expertise by failing to do their due diligence and may have been deliberately trying to deceive. If you want to know what cherry-picking in professional literature looks like, this preprint is a prime example. The Alison et al. Literature review purports to be a systematic review of the efficacy of face masks in preventing COVID-19 transmission. But with the exception of one random case report on SARS from 2004, which did not even meet the author's own inclusion criteria because it was a one-person case study where one SARS patient transmitted SARS to no one else, this review limited its analysis to 12 articles published from April 2020 to August 2020. Do you think a little thing like deliberately picking April to August of 2020 might skew the author's literature findings just a tiny bit? The 13 studies included in the Alison et al. Analysis consist of 1 retrospective cohort study, 2 case control studies, 6 surveillance, survey, or anecdote studies, 3 contact tracing studies, and 1 detailed write-up of hospital policies. Even the CDC only bothered to cite 2 of these 13 in its own science brief on masks for good reason. 9 of the 13 do not even have a control group, and at least 2 of them, insofar as they provide any evidence at all, run as much against mask efficacy as they do in favor of it. In total, the 13 studies include 247 SARS-CoV-2 infections and a total of 1,551 participants, 1,076 in healthcare and 475 in community settings. Remember, the CDC tried to dismiss the Bundgaard et al. Danish face mask study as being too small, despite a total of more than 4,800 participants completing just that one randomized controlled trial, more than twice as many as all 13 of the studies cited by Alison and colleagues in this so-called systematic review combined. A table listing all 13 studies with comments is presented in the PDF, ebook, and print copies of this book. Another 2022 study published in the New England Journal of Medicine purported to show that lifting mask mandates in Massachusetts was associated with 44.9 more cases of COVID per 1,000 students. However, this study suffers from the same defects of cherry-picked time period and dataset as the earlier Budzen et al. Study published in the CDC's MMWR. More importantly, this study's own charts clearly show that the school districts being compared experienced even greater differences in COVID case numbers during the period of time when all of them were subject to the same universal masking policy. This strongly suggests that any differences in COVID-19 incidence after the mask mandates were lifted were more than likely caused by whatever factors caused the dramatic differences in COVID-19 incidence when the mask mandates were still in place. Wrapping up the CDC's case for masks. If anything, the foregoing discussions give the CDC too much credit, because the CDC was putting its best foot forward when picking and choosing which of its MMWR publications to cite in its science brief on masks. 3 persevering researchers, Tracy Hogue, Vinay Prasad, and Alison Haslam, doggedly accomplished the mind-numbing feat of tracking down, carefully reviewing, cataloging, and analyzing every CDC MMWR publication pertaining to masks from 1978 to 2023. They published their findings in July 2023, and unlike the CDC, they made it easy for reviewers to check their work. The team's first notable finding was that the CDC had no MMWR publications prior to 2020 which pertained to masks. All of the CDC's MMWR writings on masks came from 2020 and later. In total, not including 5 guidance documents and a standalone search result, the team found 77 CDC MMWR studies on masks, 30 from 2020, 33 from 2021, and 14 from 2022. Of those 77 studies, 58 included conclusions that masks were effective, but only 23 actually assessed mask effectiveness. It gets worse. Of those 23 studies looking at mask effectiveness, only 12 were statistically significant, and only 12 had anything resembling a control group. Not every MMWR publication with statistically significant results had a control group, or vice versa. In 4 of the 12 MMWR studies where something like a control group was present, the masked group actually had more cases of COVID than the comparator group. But the studies still concluded that masks were effective and therefore essential. Hogue et al. Found that the only one of the CDC's 77 MMWR studies pertaining to masks in which causal language was used appropriately was a mannequin study with highly questionable applicability to real life. Similarly, the only one of the 77 MMWR studies to even mention data that suggested masks might not work was a study involving masks and influenza. Not a single one of the CDC's MMWR publications pertaining to masks were randomized trials or cited randomized data. The studies cited and referenced by the CDC never came anywhere close to satisfying the burden of proof necessary to sustain mask recommendations, let alone mandates. The CDC's aggregate conclusions flew in the face of mountainous contrary evidence. Characteristic deficiencies of studies set up to justify masking include, but are not limited to, lack of a control group, small size, short duration with suspiciously convenient time periods selected for analysis, selective presentation, uncontrolled and unaddressed confounders, and suspiciously unusual selection criteria or endpoints. As Ian Miller, author of one of the few accurate books on masks, aptly commented, no matter how much respect you've lost in the CDC over the past few years, it's truly not enough. What are we forgetting? Why masks do not work? The evidence base cited to support the efficacy of masks fails to consider important aspects of the problem. Filtration is just one of many mechanisms by which masks act out their real-world effects. If susceptible individuals have enough viral exposure to reach the infection threshold with or without a mask, then mask wearing will not make a significant difference in the overall infection rate. Even if it was undisputed that mask filtration properties provide infection control benefits, there are multiple additional effects associated with mask wearing that could, on net balance, easily negate or even outweigh any benefits from filtration, potentially increasing the overall risk of disease transmission depending on circumstances. Masks facilitate cross-contamination by providing an additional surface and microbial growth medium, especially if skin irritation or repeated adjustments result in more frequent touching, transport, and improper storage. We will discuss the infection control issues with masks in more detail when we cover mask side effects in Part 2. The increases in temperature and humidity on skin surfaces underneath masks enhance microbial growth, expanding the pool of microbes which can be dispersed. Normally, exhaled respiratory emissions dry quickly in free air, but when trapped in masks, microbe-laden droplets stay warm and damp. This may explain some of the study findings that we looked at earlier, how bacteria emissions through surgical masks increase in volume over just 2 hours of use until they equal or surpass unmasked emissions. We will cover this topic in much greater detail in Part 2 as well. Masks can serve as sources and launch pads for aerosolized fomites, non-respiratory particles which have been contaminated. As we saw earlier, multiple CDC-designed and mandate-compliant homemade cloth masks emit substantially more airborne particles than a non-masked baseline. Similar to how the aerator on your faucet or the nozzle on a spray bottle works, masks act like nebulizers, increasing the proportion of respiratory emissions composed of fine aerosols. A 2020 laboratory study found that when no mask was worn, 35% of particles emitted were in the smallest measured size range of 0.3 to 0.5 micrometers, 300 to 500 nanometers, still much larger than SARS-CoV-2. When a surgical mask was worn, however, this fraction increased from 35% to 46% of emitted particles, and increased still further to 60% of particles when a KN95 mask was worn. Even assuming that a mask blocks 50% of emissions under perfect conditions, we already know that having just 1 to 2% of a mask's area compromised and leaking can cut that filtration benefit by half or more. If a mask functioning at half or less of its theoretical filtration also creates a relative increase in the wearer's aerosol emissions of 25 to 30% or more, the net result becomes either no net benefit or even a net harm. So much for the slogan, "My mask protects you, your mask protects me." As noted earlier, SARS-CoV-2 remains viable longer on medical masks than on most other surfaces. Mask-associated rhinitis, nasal inflammation, laryngeal or respiratory irritation can increase respiratory secretions. More on this in Part 2. The increased resistance to airflow from masks may necessitate more vigorous inhalation or expiration, thereby generating more scary bioaerosols. Another hypothesis, based on in vivo laboratory findings and observational studies, suggests that deep re-inhalation of hypercondensed droplets or pure virions caught in face masks can worsen prognosis and might be linked to long-term effects of COVID-19 infection. This has been dubbed the Fogen effect theory. Mask abrasion on skin often releases more microbes into the air than untouched skin. Long-duration mask wearing damages skin, compromising skin's ability to act as a barrier to all microbes, not just viruses. More on skin damage from masks in Part 2. Wearing a mask can cause counterproductive behavioral changes, such as risk compensation, with wearers becoming less careful because of perceived protection. This psychological side effect of mask wearing was also noted in the 2023 Cochrane Review on Masks. More on the psychological side effects of masks in Part 2. The overwhelming weight of evidence is that surgical masks make no statistically significant difference against infections, and when directly compared to surgical masks, cloth masks perform worse. Additionally, stretching and washing associated with normal wearing causes a cumulative and rapid decline in the filtration capability of cloth masks. Study findings of higher respiratory infection rates in cloth mask wearers than when either no masks are worn or when surgical or respirator-type masks are worn raise the strong possibility that widespread cloth mask usage during COVID actually increased respiratory infections slightly above a non-masked baseline. Similarly, a case control observational study on healthcare providers treating Hajj pilgrims found that intermittent medical mask use was associated with an increased chance of acute respiratory infection, as did a case control study out of Thailand cited by the CDC. There is a final point you can easily test for yourself the next time you cough. Compare the experience of coughing without covering your mouth to the experience of coughing into a cupped hand, cloth, or good paper towel. You will notice that your cough is more productive when you cover your mouth. Similar to how covering your mouth with your cupped hand or coughing into a cloth can help make your cough more productive, masks create this same plunger-like back pressure and turbulence, dislodging more of those scary respiratory secretions held deep in the lungs. There is no net public health benefit to a filter that catches half of what you cough up if it makes you cough up twice as much material from deeper in your lungs in the first place. Part 1 Conclusion. The first part of this book has been concerned primarily with the empirical debate about the efficacy of masks in mitigating the spread of respiratory pathogens, especially viruses. In the next section on mask science, we will cover numerous additional studies which provide background information about well-documented non-trivial side effects and trade-offs that would discourage mask use and compulsory masking even if masks were effective at mitigating the transmission of respiratory pathogens. Every society already has a very effective method of avoiding infectious disease transmission. This method has been tried, tested, verified, and established over centuries of experience. It is called staying away from obviously sick people. Compulsory masking of apparently healthy people, even if it worked, would only address a small subset of risk, lethal spread of COVID from asymptomatic individuals. Asymptomatic individuals are only a fraction of total COVID cases. Additionally, multiple meta-analyses incorporating more than 150 contact tracing studies have shown symptomatic carriers of COVID to be 6 to 20 times more contagious than asymptomatic carriers, and that the chances of catching COVID through workplace exposure, even in a healthcare workplace setting, are less than 1/5 the odds of doing so through exposure in the home. Moreover, the purported lethality of COVID-19 was vastly overstated in media right from the very beginning. A French study published in May 2020 found that the mortality rate of patients hospitalized with SARS-CoV-2 was comparable to the mortality rate of patients hospitalized with other coronaviruses. In fact, this study found that the OC43 and NL63 coronaviruses had double the mortality of SARS-CoV-2. The authors concluded, there does not seem to be a significant difference between the mortality rate of SARS-CoV-2 in OECD countries and that of common coronaviruses. In January 2021, a meta-analysis by Stanford epidemiologist Dr. John Ioannidis, incorporating data from nearly 50 countries, suggested that COVID-19 had an infection fatality rate of 0.15%. In other words, a bad flu. A subsequent analysis in preprint by October 2022, which Dr. Ioannidis co-authored, found even this modest previous estimate was far too high. At a global level, pre-vaccination infection fatality rate may have been as low as 0.03% and 0.07% for 0 to 59 and 0 to 69-year-old people, respectively. According to this data, using 40 seroprevalence studies from 38 countries, the age-stratified median infection fatality rate for COVID-19 was estimated to be 0.0003% at 0 to 19 years, 0.003% at 20 to 29 years, 0.011% at 30 to 39 years, 0.035% at 40 to 49 years, 0.129% at 50 to 59 years, 0.501% at 60 to 69 years. Compulsory measures cannot be justified to control the risk from a virus which the CDC's own seroprevalence publications admit was successfully contracted and cleared by more than half of the United States population as early as February 2022. Compulsory masking was initially motivated not by science and carefully considered data-driven public policy, but by primal fears of contamination, unexamined intuition, a desire to be, or at least appear to be, helpful, a desire to make others feel better, an it-can't-hurt attitude, and in some cases, a pathological risk aversion, a conscious desire to manipulate others through behavioral psychology and/or desperate post hoc self-justification. It is worth repeating that from a public policy standpoint, it is not actually necessary to prove that masks do not work. All that is really necessary is to show that the balance of scientific evidence does not favor masks strongly enough to justify forcing all citizens to wear one. This is a much lower burden of proof than most people realize, and it has been met since the time of the Spanish flu. In a multiple-choice public health policy test, mandatory masking was and remains the wrong answer. It was the wrong answer before 2020, and it is even more clearly the wrong answer from 2020 onwards. Claims or assertions that compulsory masking is a least restrictive means to further a compelling public health interest, or that compulsory masking is somehow required by the common good, or even military necessity, simply never matched reality. In the wake of the Spanish flu, the U.S. Navy Surgeon General conducted an extensive investigation which included evaluating whether masks had been beneficial. His conclusion still holds true more than 100 years later. No evidence was presented which would justify compelling persons at large to wear masks during an epidemic. The mask is designed only to afford protection against a direct spray from the mouth of the carrier of pathogenic microorganisms, and assuming that it affords such protection, the probability that the microorganisms will eventually be carried into the mouth or nose by the fingers is very great if the mask is worn for more than a brief period of time. Masks of improper design, made of wide mesh gauze, which rest against the mouth and nose, become wet with saliva, soiled with the fingers, and are changed infrequently, may lead to infection rather than prevent it, especially when worn by persons who have not even a rudimentary knowledge of the modes of transmission of the causative agents of communicable diseases.